right. Good afternoon and welcome to this bill hearing for the House Health Committee. Today is Thursday, February 19th. Thank you for your patience while we were working through some of the tech. Please continue to be patient if we experience any technical or streaming issues. This hearing is being streamed on the Maryland General Assembly YouTube channel. We do have some virtual witnesses today. Please note that food and beverages are not allowed in the gallery. Delegates may have drinks at their desks because some of these meetings get long, and we want to make sure that people stay hydrated. If you see that we are missing a member, they may have hearings in the other committees or official meetings, but they are staying informed on their proceedings. And please adhere to our usual committee rules of one question and one answer from the panel, not one question and one answer from the panelists. Please keep your questions shorter than the answers. Also, bear in mind that sponsors are not time limited, but please keep your testimony within reason so we don't have to revisit that. And all witnesses have 2 minutes. And we are going to go in this order today. House Bill 684, 746, 865, 804, 886, 739, 633, 737, and 808, subject to people's availability, obviously. So we're going to start with House Bill 684. This is health insurance material changes to provider networks, notification and special enrollment period. And we have our amazing department here. If you want to come to the table, I've got Jesse Haviland, Marie Grant, David Cooney, and Marie Quay, Jake Whitaker, are you on? You're on the next panel, correct? So, Madam Secretary, if you want to bring your team on up.
Yeah, do it this way.
And you can get started whenever you're ready.
Great. Thank you so much, Madam Chair, Madam Vice Chair, committee members, Marie Grant, Maryland Insurance Commissioner. It's a pleasure to be here today in support of House Bill 684. This bill has a number of provisions that are intended to address what happens when a provider and an insurer go out of contract with each other, go out of network. We saw a pretty big instance of that in the past year. And I think that dispute revealed gaps in protections under Maryland law that could have kept consumers more out of the middle when that dispute happened. So currently, we have continuity of care protections on the books in Maryland under current law, but only under primary care and for specific exemptions that are covered under the Federal No Surprises Act. We have challenges about timely notice to our consumers when these disputes occur. As well as clarity about how to request continuity of care eligibility. And there's also few affirmative requirements in Maryland law currently about how our insurers need to inform the Maryland Insurance Administration of contractual challenges in advance and proactively update their network adequacy plans with our department. So this bill has a number of provisions that are intended to solve these issues and again help protect Maryland consumers and keep them out of the middle when these disputes occur. The bill requires insurers to provide earlier and clearer notice to enrollees as well as the Maryland Insurance Administration when provider contracts are being terminated. It requires health insurers and health systems that are involved in a contract dispute to adhere to their contractual terms, including reimbursement conditions for a period of 90 days following a contractual expiration or termination, so that patients covered by their insurance company can continue to see their provider while they may need to make other choices and figure out other arrangements. It provides for an affirmative obligation for continuity of care for behavioral health. It clarifies the type of notice that insurers need to use to inform members on how to request continuity of care. And it also requires insurers and health systems to give each other advance notice before ending contracts, as well as requires insurers to give 30 days advance notice to consumers before terminating a contract with a health system. Finally, the bill creates a 90-day special enrollment period in the individual market. Usually when folks are buying insurance on the individual market, they're likely basing that decision in part on the network that the insurer has and provides. This would allow patients whose provider leaves their network to enroll in a different individual policy if they so choose. We understand there's going to be some amendments offered from various folks. We've talked to the Office of the Attorney General about some of the amendments they intend to offer in detail. We're supportive of the concept, look forward to working with the committee on this very important bill. And with that, we urge a favorable committee report. And Mary Quay and David Cooney from my team are available for any technical questions on the bill.
Delegate Kaufman.
Yes, thank you. I'm just wondering, and if you don't have the answer, that's fine. Do you know how many thousands or hundreds of Marylanders will benefit from this change on an annual basis, based on past experience of how many people that have gotten caught up in this unfortunate situation?
So Delegate Kaufman, I'm going to give you a round number, not to be quoted, but in the example of the network dispute that happened this year, we're talking about, I think, 60 to 70,000 folks that were impacted by the change.
Wow, thank you very much. Thank you very much, Madam Chair.
Seeing no further questions, this concludes this panel. And you said that you have seen the amendments, but we're still working through them.
So I've seen amendments from the Health Education and Advocacy Unit, which we were supportive of. I understand there may be other amendments offered by other folks that are.
Yeah, I think there's some amendments from MedChi as well. So we'll make sure that we have the opportunity to consider and work with you.
Great, thank you.
Seeing no further questions, this concludes this panel. We do have a favorable panel. Oh, okay. Jesse Haviland and Jake Whitaker.
Madam Chair Bagnall, Madam Vice Chair Cullison, and members of the Health Committee, I appreciate the chance to provide comment in support of HB 684. I'm submitting this testimony on behalf of our individual organization, Maryland Citizens Health Initiative. Our objective is for every Marylander to have access to quality, affordable health care. The legislation offers essential consumer safeguards during contractual disputes between major healthcare providers and insurers. Patients will benefit from extended notification periods prior to a provider's departure from the network. Following a major contract termination, consumers would be granted 90 days of continued care with their existing providers. Additionally, those with individual insurance would receive a 90-day special enrollment period to switch to a plan that retains their preferred providers. These protections are vital, offering patients the necessary time and flexibility to either transition to new care or select a plan that maintains provider access. Without these safeguards, consumers may face interrupted treatment during provider transitions, potentially resulting in severe medical setbacks. We urge a favorable report for HB 684. Thank you.
Great, thank you, Madam Chair, Madam Vice Chair, and members of the committee. I'm Jake Whitaker, and on behalf of Maryland's hospitals, I'm here in strong support of House Bill 684. And we're in support because hospitals really kind of bear the cost of when things like this happen and folks lose either enrollment or access to certain providers. So for example, when a patient's primary care professional or behavioral health providers suddenly drop, hospitals really bear that fallout. So patients will show up confused, without continuity of care, and with worsening chronic conditions because they couldn't find a new provider in time. So this drives up avoidable ED visits, as well as drives up ED wait times, causes delays in treatments and frustrations for patients as well as hospital staff. We're supportive of this bill because it gives hospitals the predictability they need to maintain safe operations. So having advance notice of these network changes allows hospitals to adjust staffing, scheduling, and also care coordination. Sometimes when these sudden network disruptions happen, it affects inpatient discharges, our outpatient follow-up, as well as different referrals, which impact patient flow, bed availability, and then ultimately wait times. With early notice, hospitals can help patients transition more smoothly and avoid some of these complications that I mentioned. And I think most importantly, continuity of care is a patient safety issue, and this bill really does a lot to protect that. So it allows patients to continue seeing a terminated provider for a transition period that prevents those dangerous gaps in care. And hospitals are often have to treat those consequences when folks lose critical services like uncontrolled diabetes, unmanaged healthcare or mental health conditions, delayed cancer follow-up, or medication lapses. And so this bill will go a long way to prevent those avoidable emergencies. And so for the aforementioned reasons, we respectfully request a favorable report. Thank you.
Do we have questions from the members? Vice Chair Collison.
Thank you, Madam Chair, and thank you both for being here. So, Jake, you just described in very accurate terms the challenges that hospitals face when this negotiation breaks down. I have a background in negotiations, done it many times in my life, and it requires both sides to come to the table in good faith. So what I hear is there's an incentive on the part of the hospitals to keep their to be a network in network. And so I guess my question is, do you agree with that premise, and do you agree that there is some onus on both parties to reach agreement because it's to the benefit of patients as well as the stability of the hospital?
No, I appreciate the question, Madam Vice Chair, and if okay with you, I can circle back. I don't want to speak out of turn, so I'm happy to circle back on that one.
So, and I just would remind you that, I remind the body, you already know this, that, some patients may come back even though they're out of network. So the hospital is actually making more money because the people are paying, the people are paying more to the hospital now than they were when you were a provider. So just, I think we just need, this is a very difficult situation, and I want to acknowledge that. But I want it to be fair. And so I think, we just need to make sure that we have folks coming to the table in good faith.
Absolutely.
Thank you, Madam Chair.
Seeing no further questions, this concludes the testimony of this panel. We do have one favorable with amendments, and that is Dana Kaufman. Thank you very much for your testimony. And Ms. Kaufman, you can get started whenever you're ready.
Chair Bagnall, Vice Chair Cullison, members of the committee, for the record, my name is Dana Kaufman. I'm here on behalf of MedChi, and I actually am going to address Vice Chair Cullison's question. And yes, it is within the best interest of physician practices to be in network. But we need to step back and look at how we get into network. And at the end of the day, negotiations are not even platforms. Maryland has a situation, and this is not numbers, these aren't my numbers, these are numbers from the Maryland Healthcare Commission. The market share of the largest carrier in Maryland in 2023 was 78.3% in the small group and 65.3% in the individual market. It makes it very hard sometimes to negotiate when most of your patients are connected to one carrier. So oftentimes what we find out during these negotiations is we're not getting information back until almost the day that the contract is expiring, and then it's a take it or leave it. So when we looked at this bill, one of the things that we are very supportive, I have talked to Commissioner Grant, about some of our concerns. One of our concerns is that the bill is looking at the notice to expand it to behavioral health services when that person has been in treatment for in the last 3 months. There are, under the No Surprises Act, continuity of care provisions, but those are also narrowly defined. And oftentimes, you might see a provider on a routine basis, but not within those 3 months. And with the shortages and the workforce crisis, trying to be able to find a provider that you can transfer is very time consuming and very frustrating for patients. So one of ours was whether or not we should look at and decide whether or not that actually needed to be expanded to other specialties. The other concern that we just have is the material change to the access plan is having greater communication and transparency for providers to understand when they are being terminated or their contract is not being expanded, why, and how that carrier is still meeting the network adequacy standards, which we do support revisiting.
Thank you very much for your testimony. Are there any questions from the members for this witness? Seeing none, thank you very much for your testimony today. This concludes the bill hearing on House Bill 684, and we're now going to go to House Bill 746, and we're going to transition seamlessly.
So I'd like to call your panel while you're making your way up there, Madam Chair. So Dan Martin, Alana Aronin, Michael Gray, Kevin Roy, Kevin Roy. I'm going
to go right on the end. Good afternoon, Madam Vice Chair and members of the Health Committee. For the record, I'm Delegate Heather Bagnall, District 33C, Anne Arundel County, here to talk about my favorite subject, which is upstream access to behavioral health care. Here in strong support of House Bill 746, the Maryland Medicaid Assistance Program and Health Insurance Collaborative Care Model, cost-sharing provision. You have my written testimony, so I'm going to quickly summarize. This committee is well acquainted with the value of collaborative care model, which houses behavioral health in primary care settings, creating a holistic, teams-based model of care, and the evidence on its efficacy is extensive. In 2023, we had a pilot program which demonstrated returns in the first 2 years on better health outcomes and cost savings. And so I sponsored legislation that expanded that pilot statewide and brought our Medicaid in alignment with private pay, who had already endorsed the use of collaborative care model for their insured. Despite the proven track record of this evidence-based model, we are learning from our state partners that we are seeing a drop-off in utilization, and the decline in billing is being attributed to a reluctance to continue to pay for those follow-up visits. So House Bill 746 codifies the best practices established by Medicaid by prohibiting the imposition of copays and cost sharing for collaborative care services across all insurance plans in Maryland. Because Medicaid copays only apply to prescription drugs, prohibiting them for all collaborative care participants creates no additional cost burden on the state. Collaborative care has repeatedly proven to be a highly effective method of upstream care, and ensuring access to it is paramount to its continued success. In fact, my Senate counterpart had his hearing yesterday and spoke to the fact that he has repeatedly brought forth a bill to require mental health wellness visits, and the private insurers said, no, we already have collaborative care. We should be working for better utilization of the model. There is a letter from the league in opposition requesting that the Maryland Healthcare Commission conduct a review. And the great news is you have a letter of support from the Maryland Healthcare Commission in your packet. And they are here in person to speak to the proposal and how it aligns not only with best practices, but also with value-based care, and was included as a recommendation in their 2025 Primary Care Investment Analysis and Recommendations report. For all these reasons, I respectfully request a favorable report on House Bill 746, and will turn this over to my esteemed panel.
Thank you, Madam Vice Chair, members of the committee. Dan Martin with the Mental Health Association of Maryland, here in very strong support of House Bill 746, and thank you, Chair Bagnall, for introducing it and being our champion again for collaborative care. You know, we've been working for years to expand this model and to improve the quality of mental health and substance use services delivered in primary care settings. And you all, the General Assembly, has been right there with us the whole way. We had budget language in 2016 and 2017, studying the model, and the passage of legislation in 2018, creating the pilot that Delegate Bagnall spoke about. And yeah, in 2023, you all actually ended that pilot a year early to expand it statewide because of how great the results were. So, and it's easy to see why there's been such an effort to keep expanding this model throughout the state. It checks a lot of boxes for us. It helps us achieve a lot of our goals. It improves treatment. It reduces healthcare costs. It mitigates persistent workforce challenges. It reduces disparities in access to care. But like Delegate Bagnall said, we're hearing from primary care practices that patients are reluctant to come back for follow-up visits because they don't want to pay the copay, which really defeats the benefits of the model. Those follow-up visits are really important. The symptom monitoring and outcome measurement and treatment modifications are really the heart and soul of collaborative care. So if they're not going for the follow-up visits, it really defeats the purpose. So this bill is really simple. It would eliminate those costs to the patients, those out-of-pocket costs for patients. It's a really simple thing we can do to help Maryland patients avail themselves of this care and help the state continue to expand uptake of the model. And so I ask for your support. Thank you.
Thank you. Madam Chair, Madam Vice Chair, members of the committee, thank you for the opportunity to provide testimony today in support of House Bill 746. My name is Alana Aronin, and I'm the program manager for the Community Mental Health Corps at Children's National Hospital. 60% of our patients are Maryland residents, and we maintain a large network of community-based services in Maryland. Children's National appreciates your introductions of this legislation, which aims to increase access to and utilization of the collaborative care model by reducing cost barriers. We know that patients face many barriers in accessing mental health care, including navigating complex health systems, the overall high cost of health care, mental health stigma, and behavioral health workforce shortages. Improving Marylanders' mental health starts with reducing some of these barriers. Collaborative care model is an evidence-based model where the pediatrician diagnoses, treats, and manages the care of the patient with the support of the psychiatric consultant and behavioral health care manager. In this way, patients with common conditions can receive quality, accessible care delivered in the primary care office. Multiple studies have shown that the collaborative care model improves mental health and physical health outcomes and reduces costs in the healthcare system. In youth, multiple studies have found that the collaborative care model is useful for treating ADHD, depression, and anxiety disorders. The February 2026 Bowman Family Foundation report describes that the collaborative care model is showing rapid growth, including for children and adolescents. However, the report highlights that patient cost sharing reduces its use. Meeting the behavioral health care needs of Maryland's residents through referral and specialist care would require doubling its current workforce, according to the Maryland Healthcare Commission 2024 report. Integrated care provides a valuable and accessible alternative nearly immediately. In fact, the collaborative care model was identified in that report as a key strategy for addressing Maryland's workforce challenges. Maryland faces an ongoing mental health workforce shortage. Patients struggle to find in-network mental health care, and the pediatric mental health crisis that was declared in November 2021 continues to affect our state's children. It's our responsibility to reduce every barrier possible to improve access to quality mental health care. I applaud Chair Bagnall for introducing this important legislation and respectfully request a favorable report on House Bill 746. Thank you for the opportunity to testify.
Good afternoon. My name is Kevin Roy, and Madam Chair and committee members, thank you for the opportunity to speak on behalf of HB 746. I represent Shatterproof, which is a national nonprofit dedicated to ensure that addiction doesn't define or end a life. And we're very supportive of this legislation. I happen to be a resident of Anne Arundel County for 25 plus years, but we've worked on this collaborative care model expansion in a number of states. And so we're really delighted to support its, sort of continued progression here in Maryland. Part of what makes this such an incredible model is there's great research on it. There's 90 plus randomized controlled trials, and just one study on alcohol and opioid use disorders showed a 47% improvement in 6 months abstinence. It also has shown there are several studies also released by the Bowman Family Foundation last year on suicide reduction risk that showed one study by the University of Pennsylvania showed a 52% reduction in suicide risk, and another study in Washington State by Kaiser showed actual reduction in suicides by 26% or so. So it's a great model because it has both these benefits of both substance use as well as mental health. And so that's one of the really, strong benefits of it. In addition to that, I think the cost savings element of this is important in the literature and in, Medicaid agencies that have implemented this. They've seen reduction in costs and in savings. And we know that 20% of all costs in Medicaid are behavioral health related. Only 20% of those are behavioral health issues, but they account for half of all the costs. And so we know that this cost reduction is very, very important. So because of this flexibility, the cost savings, again, the incredible research that's been shown in both clinical trials and now real world evidence, certainly encourage you to support this bill, and we thank you for the opportunity to do so.
Good afternoon, Madam Vice Chair, Madam Chair, members of the committee. My name is Michael Gray. I'm with NAMI Maryland. NAMI is the state organization of the National Alliance on Mental Illness, and we want to thank Chair Bagnall for bringing this bill. It's a very important piece to something that mental health advocates talk about all the time, and that is the continuum of care. We talk about it a lot, and we use it to talk about the different pieces needed to treat mental health conditions in the community and across the state. But we often leave out a very important part, and that is the primary care providers. Their role in this is vital because for so many people, it is not only the front line, but also the primary way they're going to access a lot of mental health care services. So we enthusiastically support this bill and can't wait to see the continued success of this program in the state. Thank you so much.
Very much for your testimony. Questions from the committee? Oh my, you did a great job. The panel did a great job. Thank you all. I have another favorable panel that starts with Dan Rabbit. And then virtually we have David Sharp and Caden Fabi. They're both on? Okay, let's start with Dan. Hi, welcome.
Good afternoon, Vice Chair Collison, members of the Health Committee. For the record, my name is Dan Rabbit, Policy Director at Behavioral Health System Baltimore. We are the local behavioral health authority for Baltimore City, and we're in strong support of this bill. We support the collaborative care model for all the reasons that the previous witnesses mentioned, but we really see it as solving a number of problems that we see in our role as overseeing the public behavioral health system, or at least in Baltimore. One is our workforce shortage. By allowing primary care providers to work directly with patients and just consult behavioral health experts, that allows those behavioral health professionals to see many more people than they would be able to see in direct therapeutic relationships themselves. And so we think it is really a critical piece to addressing our behavioral health workforce shortages. We also see it as an important prevention and early intervention effort. By helping people who are going to see their primary care provider anyways and get screened for behavioral health concerns and allowing them to get treatment right then and there, it helps them to access services without having to deteriorate any further and need any other high-end services. When you look at other preventative services under insurance, often the copays and cost sharing is reduced or eliminated because it's recognized as a preventative intervention. And so we see the collaborative care model in that way as well. And so we thank Chair Bagnall for bringing the bill and urge a favorable report.
Thank you for your testimony. David Sharp, is it Secretary Sharp? I'm never sure of people's titles.
Good afternoon. Can you all hear me?
Yes, we can.
Okay, thank you. I'm having a little bit of trouble with sound, so if I ask you to repeat a question as we get toward the end, I request your indulgence, and hopefully I can resolve the technical challenges as we proceed. Good afternoon, Chair Bagnall, members of the committee. For the record, my name is David Sharp. I'm the Center Director for Health Information Technology and Innovative Care Delivery at the Maryland Healthcare Commission. I'm here today to testify on behalf of our Executive Director, Dr. Douglas Jacobs. The MHCC supports HB 746, which prohibits the Maryland Department of Health and certain payers from imposing co-payments coinsurance, or deductibles for services delivered under the collaborative care model in primary care settings. The collaborative care model is an evidence-based, team-based approach that brings together primary care providers, psychiatric consultants, and behavioral health care managers to support patients with chronic and complex behavioral health needs. Research demonstrates that the collaborative care model significantly improves clinical outcomes, increases depression-free days, and is effective across diverse populations of care settings. Integrating behavioral health into primary care also reduces disparities in access and supports earlier intervention. House Bill 746 strengthens Maryland's ability to access integrated behavioral health services by removing key barriers to participation. Although CMS has reimbursed for the collaborative care model services since 2017, cost sharing remains one of the most significant obstacles to adoption. Even modest out-of-pocket costs can discourage patients from engaging in treatment, particularly among low-income and vulnerable populations. Eliminating cost sharing ensures that the collaborative care model services are viewed as a standard component of primary care rather than an add-on requiring additional payment. The bill also aligns with federal efforts to strengthen primary care and behavioral health integration and is consistent with value-based care principles that prioritize removing financial barriers to high-value services. The Maryland Healthcare Commission has previously recommended that payers cover collaborative care model services without cost sharing in its 2025 Primary Care Investment Analysis and Recommendation Report, as removing cost sharing supports broader adoption and strengthens Maryland's primary care. Chair Bagnall and members of the committee, this concludes my testimony. For the reasons stated, we respectfully request a favorable report on House Bill 746. Thank you for the opportunity to present today.
Thank you for your testimony. If you can just stay on till we finish the panel in case there are questions. And Mr. Fabi, if you want to unmute and begin your testimony.
Thank you very much. Good afternoon, Chair Bagnall, Vice Chair Cullison, and members of the committee. My name is Caden Fabi, and I'm the Director of State Affairs for Inseparable. Inseparable is a nonprofit founded on the principle that mental health is inseparable from physical health. Thank you for the opportunity today to testify in strong support of HB 746. The collaborative care model is one of the most rigorously studied models in behavioral health. Decades of research show that it improves outcomes for depression and anxiety, increases patient engagement, and helps people get better faster. It works because it supports primary care providers with a behavioral health care manager and a consulting psychiatrist using measurement-based care to make sure patients are improving. The model extends scarce psychiatric expertise into primary care practices, including those serving rural and underserved populations. It strengthens the workforce we already have and makes high-quality mental health care more accessible. However, even when services are available, cost sharing can stand in the way. For many Marylanders, especially those living paycheck to paycheck, even modest copays can delay treatment. In behavioral health, these delays matter. Untreated depression and anxiety can lead to worsening symptoms, increased emergency department use, higher overall healthcare costs, and serious life consequences. By eliminating cost sharing for collaborative care services, HB 746 removes a clear and predictable barrier to care. It affirms that integrated mental health, treatment, and primary care is essential healthcare. This approach is also fiscally responsible. Evidence shows that collaborative care reduces total healthcare costs over time by improving chronic disease management and reducing use of high-cost services. HB 746 strengthens Maryland's behavioral health infrastructure, supports primary care practices, and makes it easier for patients to say yes to care. I respectfully urge a favorable report. Thank you.
Thank you for your testimony. Are there any questions from the members for this panel? Seeing the, Delegate Riley.
Thank you, Madam Chair. So I was looking here, so collaborative care model, I get it, and I looked at step-by-step process. So with the cost sharing part of it, so does the psychiatrist, the consultant team, does the PCP, do they all get, is what this bill is doing so they're not able to charge a copay for any of those, because it's like 4 different people that are in the team, or because I think that's the issue, right? Because they're all the patient is being charged a copay from all 4 of those folks currently, and this is eliminating that and down to 1 or 0.
Yeah, and I would welcome the Maryland Healthcare Commission who did a report on.
I think Secretary Sharp might be able to answer that.
Probably be the best.
Okay. I'm happy to take that on. Thank you for the questions. So the collaborative care model consists of various services that are eligible to be billed under what's called the collaborative care model. What the cost sharing elimination would do is that 20% that requires the patients to pay with every encounter would no longer exist. And it would eliminate the responsibility from the patient to pick up this portion of the fees. More than likely, the carriers would then end up covering that additional 20%.
That 20%, okay, that's what I thought. All right, thank you for the clarification, appreciate it, thank you.
Happy to help.
Thank you for the question. Any further questions from the members? Seeing none, this concludes the bill hearing on House Bill 746. We're now going to move to House Bill 865, Health Insurance Remittance Advice Interest on Late Paid Claims. This is Vice Chair Cullison. Again, we transition seamlessly. So Vice Chair, Madam Vice Chair, if you want to approach the table and go ahead and bring your sponsor, your panel. And you can begin your testimony when you're ready.
Yeah, there she is. It's like, where's Dana? Good afternoon, Madam Chair and members of the committee. I'm Bonnie Cullison, here to present House Bill 865 to you today. I'm sort of feeling like I might just need to take a permanent seat here. It's not over yet, folks. Thank you for this opportunity to present the bill. It really is a very simple bill. It seeks to standardize the itemization of remittance from payers, those are insurance carriers, so that the amount paid to a claim is separate from what the late pay, the interest payment is. Under current law, if a claim is paid late, after 30 days, the payer is liable for interest. And that interest goes from 1.5 to 2.5% with each increment of 30 days. It also requires that the remittance give the dollar amounts. And in the bill, it says not only do they get the dollar amounts, but they itemize the claim and the interest. It would help for standardization, for the hospitals to be certain about how much they were getting paid for a particular claim, and they could also see that the interest was paid. So some payers, I understand, may actually be doing this already, but not everyone, and this would be a way to codify the practice for those who might not be doing it at this point. Thank you for your consideration, and I respectfully request a favorable report. And who would like to go first?
I can go. Again, for the record, my name is Dana Kaufman. I'm here on behalf of both MedChi and then the American College of Emergency Physicians, and we are in support of the bill. And as the sponsor, Vice Chair, said, it looks like it's a very simple bill, but I think the impact is a lot more than what it just looks like. You're going to hear a lot this session. There's a couple bills on really about prompt payment and the carriers paying for claims as they've been submitted and not reduced amounts. And for us, when I looked at the bill, I thought of two things. One, this will also ensure compliance, because oftentimes it's not like the carriers are sending, a check or a payment for each individual claim. It's usually, it is grouped into bulk payments. So by separating out the itemized, we can also make sure that the law is being followed when a payment has not been done along the line of the statute for prompt payment. So I think one will help with compliance, and two, just for the physicians, it will ensure better accounting for their system so they know what is being principal and what is interest, and for submitting those types of information, for taxes and just for financial planning. So even though it looks small, I think that the implications are large. So we would ask for a favorable vote. Thank you.
Great, thank you, Madam Chair. Jake Whitaker on behalf of Maryland's hospitals, here to testify in strong support of House Bill 865. We're in strong support because what this bill really does is it helps us focus on caring for patients rather than just a bunch of administrative paperwork. Right now, hospitals spend just way too much time dealing with insurer delays, finding out what they owe, and just determining even just what payments are late and when they're owed interest. So this bill really helps us reduce the manual reconciliation and frees up that staff time to support patients and not do all that paperwork. This bill also helps support the financial viability of hospitals, and I think this is critically important as we move into the AHEAD model. And that clear, accurate payment information really helps hospitals plan staffing, maintain services, and also avoid revenue uncertainty, especially with some of the federal cuts that we're experiencing. More adequate cash flows help us to maintain staffing, additional resources, and reduce wait times in the ED. And I think most importantly, on top of all of these administrative burdens or just even figuring out what we're owed, we're dealing with that on top of rising payer denials, increasing practices that result in lower E&M codes, as well as higher deductible plans. So for the aforementioned reasons, we respectfully request a favorable report because we can focus more time on caring for patients rather than arguing with insurance companies. Thanks.
Thank you for your testimony. Are there any questions from the members on this bill? Delegate Hill.
Thank you, Madam Chair. Madam Vice Chair, since you don't get a chance to come back, the League the League of Life and Health Insurers of Maryland has asked the question, but why? So if the original remittance shows what was billed and what the interest is, why do they have to do it again separately? Why is this now you're looking at me confused. Okay. Once again, the question from League members is why? Healthcare stakeholders have sophisticated billing systems that eliminate the need for basic transaction details. Enforcing new remittance reporting on top of these existing practices does nothing but increase costs. The bill actually says that, right, the language of the bill says that this has to be in addition to the regular remittance. There has to be a second remittance that, it doesn't say that the remittance has to spell out the interest. It says there has to be a second one.
So my interpretation of the language was, if the remittance has both those things, then it's only required one time. That's the point, is to get the information about which is the claim and which is the interest.
Okay.
If they're interpreting it as a second one, we can fix that.
So there could be qualifying language if they are correct.
Right.
All right, thank you. Thank you, Madam Chair.
Thank you. Seeing no further questions, this concludes this panel and the bill hearing on House Bill 865. We are now going to move to House Bill 804, Establishment of Aging Resilience Fund Establishment. Delegate Wallach, welcome. And if you want to bring your panel, and you can get started when you're ready.
Good afternoon, Chair Bagnall, Vice Chair Cullison, and esteemed members of the Health Committee. For the record, I'm Delegate Sarah Wallach, here to present House Bill 804, the establishment of the Aging Resilience Fund. Thank you for the opportunity to testify in support of this bill today. In these challenging times, one of the bright spots is that Marylanders are living longer than ever before. In 2000, the 60-plus population represented just 15% of all Marylanders. Looking to 2030, our 60-plus population is expected to represent 26% of the population. The Maryland Department of Aging is a fundamental tool in connecting our aging population with resources, protecting their autonomy to age how they choose, and facilitating cross-sector collaboration that builds awareness of the economic and social contributions of older adults. Each passing year, more and more aging Marylanders will be turning to the services provided by the Department of Aging, and it is imperative that we continue to support their efforts. While state funding for the Department of Aging for fiscal years of 25 and 26 and the proposed budget for 27 have remained largely consistent, around approximately $40 million, give or take, federal funds have substantially decreased over the same period by $8.3 million. Given our current state budgetary challenges alongside federal funding uncertainty, This is the moment to diversify the department's funding to ensure its mission and programs remain sustainable and that the department is able to serve more individuals across the state. The purpose of this bill is straightforward. It is to establish a special fund named, quote, Aging Resilience Fund within the Department of Aging that represents the department's mission to develop innovative approaches to aging, advance multi-sector collaborations, provide equitable access to resources. This special non-lapsing fund will consist of contributions from external sources, monies earned from investment earnings of the fund, and any fees collected by the department per its statutory authority. This fund will support the DOA personnel, partnership development, and any program, services, or activities the department oversees. There are various state and nationwide foundations and organizations that fund aging initiatives that might be interested in contributing to such a fund. Some examples include the Stolman Foundation, which makes contributions in the field of health and aging and already has a relationship with the Department of Aging. And I'm fortunate today to be joined virtually later on by a representative from Grant Makers in Aging, a trusted network and resource for funders and champion for aging-related issues and investments nationwide. And another example is the Robert Wood Johnson Foundation, which has funded Caregiver Collaborative with the Department of Aging, just to name a few. The Department of Aging has 5 key goals, with the number one being to modernize Maryland's aging infrastructure through improved cross-sector collaboration among government, public, nonprofit, and private organizations serving older adults. The flexibility of this fund to support all DOA programming embodies this aspiration to be modern and collaborative. I've worked closely with the department on the development of this bill, and they're here today in support. We expect there is no fiscal note. The DOA can administer this fund with existing resources. I thank the committee for your consideration of House Bill 804 and urge a favorable report. Thank you.
Good afternoon, Chair Bagnall, Vice Chair Cullison, members of the committee. My name is Jenna Carley, and I have the great honor of serving as the Deputy Secretary for the Maryland Department of Aging. I'm here today to testify in support of House Bill 804, Department of Aging Aging Resilience Fund establishment. Our department was thrilled to work with Delegate Wallach on this bill. We'd like to thank her and also Vice Chair Cullison for the guidance they provided. MDOA has appreciated the opportunity to come before this committee previously to share about how Maryland's aging population is rapidly growing and how we plan to address it through a multi-sector planning process as identified in the Longevity Ready Maryland Plan. This bill is timely and is in part setting up the infrastructure for our state to be better positioned to address this population disruption. As the fiscal note reflects, we can do this with existing resources. Given our state's continued fiscal constraint, looking outside of state government for funding is something that our administration has prioritized. During our tenure over the past 3 years, we've consistently pursued federal grant funding and valuable technical assistance awards funded by national partners and philanthropic groups that have helped us stretch our very limited resources and inform critical program design. We've prioritized developing relationships with these philanthropic organizations and are committed to continuing to do so, with the goal of having more funds spent in Maryland in the coming years for the benefit of older Marylanders, their families, and caregivers. Establishing this new special fund is exactly what we need, and we need it now. It will give us critical flexibility to accept and leverage outside funding from philanthropy, other private funding sources, and even individual donors, both large and small. We've proposed necessary guardrails on this fund so that future expenditures must align with the scope of the department's work prescribed in statute. For these reasons, the Department of Aging respectfully urges a favorable report for HB 804.
Hi, good afternoon, Chair Bagnall and Madam Vice Chair, members of the committee. My name is Allison Siborowski, here today on behalf of Leading Age Maryland. I'm excited to be before you in strong support of House Bill 804. As you know, Leading Age Maryland is a community of nonprofits in Maryland who provide aging services. Our members provide housing services and care to more than 20,000 older persons each year. The Maryland Department of Aging is a critical backbone for Maryland's aging network. It provides leadership, coordination, and oversight for programs to support older adults in remaining independent, healthy, and connected to their communities. We all know there's not enough money in the state to do all of the things that we need to do, and this fund, in short, will ensure that there are ongoing creative ways for the department to be able to support the work that is so needed to really ensure that we are a longevity-ready state. As was noted earlier, there's a really robust community of funders focused on aging in Maryland, which is a great opportunity, and I know the department has strong relationships with those funders. And especially at this time of uncertainty at a federal level around funding for many of the services and supports that older adults rely on, this fund is more important than ever. So all of that being said, we are in strong support of House Bill 804 and would urge a favorable report. Thank you.
Good afternoon. My name is Carol Leinhardt, and I am the retired director of the Harford County Office on Aging. I am a past president of the Maryland Association of Area Agencies on Aging, and I'm here today as the co-chair of the Maryland Senior Citizens Action Network. I've been in the aging field for over 50 years. I'm 82 years old, and I'm still coming down to talk to you about important issues. I'm also here as the poster child for a revolving fund. In Harford County, 25 years ago, the Harford County Council established a revolving fund that they call the Harford County Senior Emergency Fund. And when I took my position, there was $63 in that fund. And we did some major fundraising with a mall walkathon and put $11,000 in the fund. And I called them yesterday to find out how much money we have now. It's $115,000. And that has come from fundraising efforts, from donations from foundations, from seniors who want to recognize their friends who may have died. So we have memorial gifts. Churches give almost on an annual basis to our fund. And we are designated as a United Way agency so that county employees can recognize and give money to the Senior Emergency Fund. And over the past 25 years, we have literally helped thousands of seniors with sometimes things as small as a $26 bag of heating chips for the furnace. We bought a pair of diabetic shoes for a woman who was caring for her husband with cancer, all kinds of things. And we administer the fund through our own Office on Aging, and therefore there are no administrative costs. And you can say to someone who gives money to that fund that every dime that they have given is used to help seniors in need. And I don't need to reemphasize the fact that you as legislators know that there is no way that government alone is going to be able to fund all the needs of seniors. So this is a great idea, and we encourage a favorable report.
Thank you very much for your testimony. I'm going to open it up to our members for questions. Delegate Morgan.
Thank you, Madam Chair. Delegate, thank you for the bill. Interesting concept. It's almost like the state government is starting to creep a little bit into the nonprofit sector. So I guess the theory here is we're going to create a fund. There might be some seed money that comes into this, maybe, but most of this fund you're anticipating being funded through private sector donations, grants, and other big corporations maybe donating to it. You're shaking your head, yes, that's probably it. My question is, since it's a special fund, Maryland's had a bad track record of collecting money for the best reasons and then turning around and using it for something else. This year's in the budget, there's money for what we call SEEF funding, Strategic Energy Investment Fund. They've transferred $500 million out of that fund in the last 2 years, balancing the budgets on the back of ratepayers. Have you thought about lockboxing this or anything like that? Because I would hate to see something get funded for helping seniors and all of a sudden it ends up like the mortality healthy babies program that we had. So go ahead. turn the floor over to you.
Yes, thank you for the question. Appreciate it. And yes, we were thinking about sort of how do we make sure that the funds go to the purpose that we're hoping it would. And so the bill language says specifically that the fund and its monies can only be applied to the mission of the Department of Aging. It's explicitly in the language there, and it refers back to the statute that we have for our state.
Okay, thank you. Thank you, Madam Chair.
Thank you. Delegate Gazzoni.
Thank you, Madam Chair. I'm just sort of curious about the sort of putting in for grant money, because my understanding is that oftentimes grant makers are quite specific about how they want the money used. So it's almost like the flip side of Delegate Morgan's question. How do you work around money for specific things? So it doesn't just go into a general fund. It's sort of the grant maker is telling you what they want you to do with the money.
Thank you. If it's okay, I'm going to refer to
whoever's best to answer. Yeah.
Sure. So thank you for the question, and it's a good one. The statute actually outlines the purposes of how these dollars could be utilized, and so that is part of the guardrail process that we anticipate applying as part of establishing this Aging Resilience Fund.
Can I just do a quick follow-up? So, sorry, I lived in the grant world for a little while. I just want to ensure that everybody's clear that the grants will have requirements for reporting back to them. Like if you have a lot of them, the administrative burden grows. And I just want to make sure that that's clear, that keeping track of your grants and how you're spending them and how it's getting divided up is an additional burden to the organization, your organization.
I wouldn't classify it as an additional burden to our organization. We actually have quite a robust administrative process that we've recently stood up using technology, modernizing a lot of our formerly manual processes, and those processes can be readily adopted, as well as what we have found by taking very manual, labor-intensive processes and utilizing more standard process through technology. And what we're using right now in the absence of a larger database is smart sheets. And we've actually seen impressive savings, both from a human capital perspective as well as just overall standardization of that process that has been really beneficial to our department.
Great, glad to hear it. Thank you.
Thank you.
Delegate White Holland, followed by Delegate Warman.
Thank you, Delegate, for bringing this bill, and thank you to your panelists. As someone who also operates or has worked in the nonprofit space, this piqued my interest. And I wanted to know, we were having conversations about grant making, but I also wanted to know, given this special fund, if it also opens the door to pursue and have greater collaboration and working with the philanthropic partners to ensure that there could potentially be a public-private partnership instead of a grant making, or is it an either or a both and in this particular instance with this fund? Go ahead.
Yes, thank you for this question. It's a both and. What I will say, during our tenure at the department, we have worked really closely on building collaborative partnerships. That's across state agencies, it's with all of you, and it also includes nonprofits and philanthropic partners as well. And so what this fund would allow for, and where we actually have interest with some Maryland philanthropies, is how can we come alongside each other and grow those investments through both what we grant and then through those philanthropic dollars. And that's really what the purpose is of this specific fund.
Thank you, Madam Chair.
Delegate Warman, followed by Delegate Johnson.
Thank you, Madam Chair, and thank you for bringing the bill, Delegate. And this is kind of based off of Delegate Guzon's question, is how much do we, and I don't know if you know the answer to this, but how much do we anticipate of this fund to go to administrative costs versus direct expenses, direct services.
No, the department has stated that they don't expect any additional administrative costs. And so all the monies in the fund are for the purpose of the mission of the organization and its initiatives.
Okay, thank you.
Yep, thank you.
Delegate Johnson.
Thank you, Madam Chair, and thank you, Delegate, for the bill. This is a great bill. So you mentioned some things that you purchased for seniors, and some of them were small but important things. So now that you bring more partners on board, who will be making the decisions on the disbursements and what they're dispersed for?
So the authority will remain with the department in terms of how they spend the monies in this fund. It will not be external decision makers on that.
So will the parameters of how large or small, will that change?
In terms of the size of the grant?
Yes. As far as the purchases for individuals.
So I think you're referring earlier to an example that was given for Hartford County.
Yeah.
They were using their fund for those types of purposes, purchasing items. I don't believe that's sort of the vision for the Department of Aging. It's more related to supporting the initiatives within the mission of the organization.
Okay, thank you for the
So
clarity.
further buttressing the
Yep.
work that's underway.
Thank you. Thank you.
Delegate Rosenberg, followed by Hutchinson.
Thank you, Madam Chair. Baltimore City recently announced that it was closing the Waxter Center, which was a building for seniors 50 years old. Deferred maintenance issues that were too expensive to repair. Is this an isolated incident, or what knowledge do you have of the health, if you will, of the buildings where senior citizens congregate and receive services from the government?
Thank you for that question. We too share that concern about the Waxter Senior Center. Those buildings, almost, well, I would say all of the senior centers are managed, operated, and owned usually at the local level. And so the Waxter Center is a place where congregate meals are delivered, where health promotion activities happen. I can't speak to the overall wellness of the buildings. We do have a senior center operating fund, and then also where we're able to provide support via grant for actual activities usually within senior centers that are operated by the department. We also have the Senior Center Capital Fund, which allows for a loan of up to $800,000 that local agencies or local counties, city can apply for.
Can I follow up? How much money is in the capital fund currently?
I don't know how much is actually in the capital fund, but I know that the grants are up to $800,000.
Up to 800,000? Okay.
Yes.
Delegate Hutchinson, followed by Delegate Shaleka.
Thank you, Madam Chair, and to whoever is the best to answer this. But A, has this been done successfully in another department within the state, or have you seen it in another state where this has been done? Because I'm just trying to grasp, you mentioned like the Robert Wood Johnson Foundation, that they would just go and give the state of Maryland some money without knowing the specific purpose of what that money is going to be used for. So
Yeah.
help me get comfortable with this.
Yes, thank you. Thank you, Delegate. And thank you for that question, and it's a good one. And no foundation is going to give us money just for the sake of giving money. So I want to be clear about that, and we recognize that. It would be with a distinct purpose, a scope of work, and ultimately there would be requirements for receiving that funding. In terms of what other states are doing, we have researched this, and to our knowledge, there is not another state that has an aging resilience fund in the way in which we've set it up. However, I want to follow that up by other departments of aging across the nation are organized in a very different way than our department is. So as an example, Pennsylvania receives lottery funds from their state legislature through the budget, and that helps to fund all of their aging services. Ohio recently, last year I believe it was, received a $40 million investment, allowing for a minimum of $100,000 grants to each of its counties. Our budget on a good day is just under $90 million. So that kind of puts it into perspective as to the level of funding that we have. And then the other thing that I would just comment on is that services for older Marylanders are funded throughout a number of our state agencies. But we did an analysis, and that the Department of Aging solely receives 5% of the total state budget to create and plan for older Marylanders, which are over 1 million, age 65 and older. And so what this fund would allow for is, it's the mechanism for creating those funding partnerships. We don't have that commitment right in this moment, but this fund would allow us to begin pursuing those opportunities, and not just with philanthropies, but with others, other sources of funds.
So just a follow-up, please. So you're not replacing, we're not competing against existing well-run nonprofit organizations assisting the aging. You're a mechanism to get this funding and then to say, hey, this funding is for food insecurity or whatever the need may be.
Yes.
And now we're going to take that and fund those nonprofits with this money that's come directly to us, to those that we think are most appropriate.
Yeah, go ahead.
I was just going to say, a lot of foundations that give money are not operating foundations, so they themselves are not, operational. They are looking for partners who can operationalize the dollars that they have. So Department of Aging for those kinds of entities is a lovely partner, because it's a government entity. It has all of the sort of stewardship built into it. The mission is there, there's staff. And so having a partner who can operationalize, if I can say that word, the monies is just fantastic. And there are a lot of non-operating foundations in our country.
Fantastic. Thank you so much.
Thank you. Delegate Shalega.
Thank you, Madam Chair. Thank you for the bill. I was on the Commission for Aging for a number of years. Good to see you again. So I'm reading the bill. It says on page 4 that, and I think you said that to Delegate Warman, the purpose of the fund is to support the implementation of the department's mission. So isn't this what the state government should be funding? Isn't that the state's obligation to fund the department's mission?
I'll take it first and then I'll...
One answer per question. Sorry, that's the rule here. You may not know that.
Okay.
Sure. So absolutely, it is the state government's mission to be funding this. What we are seeing is with the rapid growth of older adults within our state and across the nation, there is not enough funding that has been designated, allocated for older Marylanders and across, and what we have experienced is there are a lot of headwinds that we are managing. And as we are experiencing it, along with American Rescue Plan dollars, the ARPA cliff that I'm sure everyone has heard about, our budget, as we talked about earlier, is $8 million less than what it was. The federal dollars are level funding currently and actually have been under significant threat over this past year. And so what these dollars do is actually, what this fund potentially does is help to supplement and come alongside those federal dollars, the state dollars that we already receive, because we know it's not enough any way you slice it. The other thing, if I may say, is that another challenge, and to give an example of state funds that were utilized, a couple of years ago, the legislature provided $8 million to supplement the senior care program, which is a program that is designed for people to age in community, provide small grants, and really does help people to avoid nursing home placement. I will tell you, our AAAs, our Area Agencies on Aging, were incredibly reluctant to spend that $8 million surplus because it was one-time funding. And so what they were concerned about was that they would start services and then have to take them away. So part of establishing a non-lapsing fund is that these dollars can be utilized not just in a 12-month period, but they can be interest-bearing, and we can use them for standing up programs that perhaps take longer than just 1 year and provide predictability.
Yeah, I would mention the ARPA funding was that same one time. So much of that was that. So I understand that's how federal dollars come in. But I will tell you, I'm very concerned about lines 14 through 20 on page 4, that you're going to use this money to pay administrative expenses and personnel and partnership development. And I do understand all that, but at a time where the governor is sending $10 million to Pfizer, you know, and I'm not sure I would agree with you that there isn't money. There just isn't the right priority. So your solution is to go to the private sector and ask them to fund something the government should be funding. Thank you.
Thank you. Seeing no further questions, I just had a question, just for my own edification, because I know you had spoken to that this was, in the article, that this was the support of the mission in the article. Am I understanding that you're referencing where it says, are important to the well-being of seniors in the state, including programs and services in the areas of income maintenance, public health, mental health, housing and urban development, employment, education, recreation, rehabilitation of seniors with physical and mental disabilities, develop a statewide plan. That's all the mission that the fund is referencing, is that correct?
Yes.
Okay, thank you. And would this bill allow you to leverage philanthropy, to expand, to further deliver for our aging population, to focus the funds specifically on needs-based initiatives?
That's right.
Okay, and I just want to make sure that I'm understanding it, because we had a lot of conversation. And it would, because it's non-lapsing, to your point, you could evolve as the mission evolves for Longevity Maryland without having to come back and change the statute. Is that correct? Because I know sometimes when we have special funds, they are also time limited, to your point. So this would allow us to not have to come back and change the statute in order to access the funds as the mission evolves for Longevity Maryland. Is that correct?
That's correct.
Okay, thank you. That does help. Are there any further questions from the members? All right, seeing none, we do have one virtual witness. We do have a favorable panel. So thank you very much for your testimony and for this bill. And we have Emily Hinsey. All right, if we can bring up Ms. Hinsey. And Ms. Hinsey, if you want to unmute and start your testimony.
Hello, thank you. Chair Bagnall, Vice Chair Cullison, and members of the House Health Committee, thank you for the opportunity to testify today in support of House Bill 804. My name is Emily Hinsey, and I'm the Chief Program Officer for Grantmakers in Aging. Grantmakers in Aging is the national network of philanthropic organizations focused on aging policy and system coordination. To support peer learning and maximize impact, we convene a multi-sector plan for aging funders community whose members collectively have invested more than $5 million to advance these state plans. Maryland has already shown leadership through Longevity Ready Maryland, the state's multi-sector plan for aging, and House Bill 804 would build the operational capacity needed to activate that strategy. Most existing aging funding supports specific services like meals, transportation, or case management, and those dollars cannot legally be used for cross-agency coordination, partnership development, or system planning. The Aging Resilience Fund fills that gap by giving the Department of Aging the ability to convene partners, to work with health systems and community organizations, and to implement a statewide strategy. Without flexible infrastructure funding, agencies can deliver programs, but they cannot build a coordinated system. Across the country, we are seeing states establish similar mechanisms to implement aging plans and attract outside investment to better align housing, health, and caregiving systems. And it's that implementation capacity, not planning alone, that can make those outcomes possible. Philanthropic partners invest where states demonstrate readiness and coordination, and a dedicated fund signals that Maryland can align public and private resources to catalyze and sustain the innovation needed to realize the benefits of longer life. GIA would welcome the opportunity to serve as a resource as this effort moves forward, and we hope the committee will move the bill ahead. Thank you for your leadership and for your consideration.
Thank you for your testimony. Are there any questions from the members for this witness? Seeing none, thank you very much for your testimony today. This concludes the bill hearing on House Bill 804. We're now going to move to House Bill 886, Certified Peer Recovery Specialist Coverage under the Maryland Medical Assistance Program and Health Insurance and Workgroup on Certification. Delegate Hornberger, welcome, and if you want to bring your panel, and you can get started whenever you're ready.
Thank you, Madam Chair. Good afternoon, Madam Chair Bagnall, Vice Chair Cullison, members of the committee. Kevin Hornberger on behalf of HB 886. This bill is very near and dear to Cecil County. As many of you have heard in the past, I'll get up on the floor and kind of talk about how we have a disproportionate amount of substance use disorder. And we found one of the most effective ways to augment that is through the Certified Peer Recovery Specialist model. This bill seeks to do two main things. One, increase availability. And it does so through different funding mechanisms, which we'll go over the fiscal note here shortly, but also convenes a work group and builds on the importance of the 2018 study that's referenced in the fiscal note on the bottom of page 2 that I would draw your attention to for review. We believe that this is one of the best ways, evidence-based and backed, that seeks to cut down on folks relapsing and folks going back towards alcohol use, substance use, and the like. We feel that this bill, as it sits now, makes good on those promises that were made to expand the capability of these services, because right now they have a very limited scope of where they can operate. And as a result, the folks that need it, whether they be in the community, healthcare environment, or even if they're experiencing homelessness, this will give them the availability to access those services. I'd also draw your attention to the fiscal note, whereas 60% of these reimbursements are covered by the federal government, and we're only looking at roughly less than $10 million outlay, which in the grand scheme of things, I know you guys deal in big numbers here. For the value that we get out of those dollars spent, I think it's tremendous. The fiscal note does not indicate all of the dollars that will be saved by those folks not relapsing. So I think that's important to capture here, even though it's not mentioned. And with that, I want to turn it over to my panel.
Chairperson Bagnall, Vice Chair Cullison, and members of the House Health Committee, thank you for hearing testimony on House Bill 886. I'm Sue Ann Blumberg. I'm the CEO at Upper Bay Counseling and Support Services. We serve about 3,000 clients a year in both Hartford and Cecil counties, and we have folks from early childhood through seniors and providing an array of services. Upper Bay, which we would like to, I want you to know how peer supports, and you're going to hear some great testimony from the rest of this panel. So I'm picking and choosing what I talk about because theirs is compelling. Peer support involves emotional support, respect, empowerment, shared responsibility, hope, self-determination by using lived experience and knowledge to support those in early recovery from substance use, mental health, really any behavioral health issue that's going on. Peer support is recognized as an evidence-based practice and an essential component of recovery-focused systems. And I think there's some concern that there is, maybe this doesn't have a lot of data to back it. It has a lot of data to back it. And it actually is, in my estimation, one of the things that turned the tide in Cecil County with the high rate of overdose and people dying. The peers were the ones that were out there getting those folks going where they were and getting them to therapists, to treatment, to wherever they needed to go. And everybody actually needs that. The high demand for behavioral health services in the state of Maryland, if we use paraprofessionals like peer support and others, it reduces our costs. It also helps free up time for clinicians. So if I, as a clinician, am working with a peer, it's going to be a great day. So I ask for a favorable response to House Bill 886.
Good afternoon. My name is Gary March. I'm a peer recovery specialist at Voices of Hope in Cecil County. Thank you, Chairperson Bagnell, Vice Chairperson Collison, and members of the House Health Committee. I began my journey as a peer 11 months ago, and I've learned that being a peer is more than a title. It means showing up on someone's hardest days, listening without judgment, and walking beside them as they rediscover strength and hope. It's a responsibility I carry with pride. As a nonprofit, we are proud to tell those who come to us that our services cost nothing. There are no bills, only support and community. But as a grant-funded organization, our future is uncertain. Funding can be reduced or disappear at any time, and that uncertainty affects the people and families who rely on us. This bill would provide stable funding by making some services Medicaid billable. All recovery community organizations would be able to allocate sustainable funds to their funding streams, reducing reliance on grants alone. It would allow us to plan, grow, and serve without fear of interruption. Most importantly, it would bring us closer to our vision of a community where everyone affected by substance use disorder finds hope, healing, and a supportive community. With your support, we can continue building that future. Thank you, and I'm asking for a favorable report on HB 0886. Thank you.
Good afternoon, Madam Chair and members of the Health Committee. My name is Aaron Wright. I'm the General Programs Manager for Voices of Hope. Voices of Hope is the largest peer organization in the state of Maryland. Out of 68 employees, 65 of us are in recovery from substance use and mental health. With that being said, even with the support of this bill, only 5% of what we do, what I would consider as clinical services. What I'm about to speak about is a case as Maryland as a whole. Cecil County, since we were established in peer support, we have reduced Cecil County's overdoses by 60% from 2020 to 2024. We have since then integrated to Harford County, and since then, peers now are in the thousands and are integrated in behavioral health as far as treatment centers, working with Sheriff's Department, EMS, hospitals, you name it, we're in there. All of us, though, are relying on grant funding. And I want to take a picture. If that were to go away, what would happen to the overdose rates? Opening this up to set a committee for certified peer recovery specialists in a clinical setting to bill Medicaid is just a smart move in my aspect. We build trust, and we can absolutely help not only hopefully eradicate overdose fatalities, but make a significant impact, as the Delegate Hornberger said, the recidivism rates. And yeah, so thank you. I hope that you would support HB 886.
Thank you for your testimony. Are there questions from the members for this panel? Delegate Riley.
Thank you, Madam Chair. First of all, welcome to both of you. And I do know both of your organizations are impeccable. Been there many times, and the stories are true. So thank you for sharing some of those personal views. I don't know if Delegate Hornberger, if you saw some of the opposition. Did you see the League of Life opposition?
Yeah, I did. Overwhelmingly, the opposition was based on fiscal reasons.
Okay.
They don't
okay.
believe that the funding is available. And what I want to reiterate is that cost overall will go down. And you can look at the bottom line there in the fiscal note, aggregate under 20 million a year, 60% of that is covered by the federal government. So for what those dollars are getting you, they're going to go a lot farther, and I think ultimately this would be net neutral.
Okay, can I have a follow-up, Madam Chair? Thank you, and I guess this would be for either Upper Bay or Voices of Hope. So in that letter also, not only, the cost, so I want you to be able to explain or, let me know how you feel about some of the comments in the letter. It said that one of the issues for the insurers would be that it's non-clinical in design, and there's actually no medical treatment. How would you feel about or explain that?
You want me to take it? Go ahead. So I read that and I cringed. So part of the recovery process is there isn't a straight line, and there isn't like one thing, because if there was, that's what we'd all be talking about, the same thing. There isn't. It takes multiple layers for someone to get and stay in recovery. It really takes a lot for someone to get into recovery to begin with. So there is an abundance of evidence. It's an evidence-based practice, which means it's clinical, right? Become an evidence-based practice without wonderful years of data on it being effective in what it says it's doing. So I read that and I thought somebody just didn't know what to say, and they wrote those words and thought we'd all ignore them. I don't know. Yeah.
Thank you very much.
Thank you, though.
Oh, Delegate Martinez.
Thank you, Madam Chair, and thank you, Delegate, for the bill. I think peer-to-peer navigation is really essential in all healthcare models, and so I wanted to ask, are there other states that are already providing this coverage, and if so, could you outline what states those are?
Yeah, I did a quick internet search, and this is a nationwide model. And if you look at the language for the work group that we want to convene in the bill as well, it does seek to look at things like reciprocity and best practices from other states to incorporate in our model. The one good thing is that these guys are already showing tremendous amounts of impact, right? Like, this is measurable. We went from the worst in the state, above Baltimore City overdose rates, to now these lower rates because of the work that they've done. So I think not only can we build on that, but I think the end product of the work group could be something that could be shared nationwide as a model.
And then I have a follow-up, Madam Chair. For the actual navigator or the support, could you talk about just how you utilize your tools or what you know to reach hard-to-reach or marginalized communities in particular that maybe traditional models just aren't reaching?
Sure, absolutely. So our model is like a stages of change model, if you will, right? All the way from pre-contemplation, from not thinking about trying to stop using drugs, all the way to how do we support someone with decades in recovery. With that model, we do outreach in those devastated neighborhoods, affected by poverty, low income, right, homelessness, encampments, whatever the case may be. So that's how we incorporate our model. Is trying to, anybody that cannot get to our services, we absolutely will take it to them, as well as if transportation or insurance or ID is even a barrier, we have found loopholes to reduce those barriers as well.
Thank you for your work.
I would like to just add one thing to that, is that Voices of Hope.
It's one.
Yeah, unfortunately.
Oh, no, I'm sorry.
I had a question, though. Did you have anything to add?
Thank you. Is that, like, nobody works in a silo. So Upper Bay, we're calling Voices of Hope and saying, geez, we have this person. They've come to our assertive community treatment team. They're in a residential program. We need your help. And they'll send a peer over. And vice versa. Look, we've got this person. They have some significant mental health stuff going on and also substance use. Can we work together with this client? And that's what makes this successful, is when the county works together. And I can tell you, Cecil and Hartford County, getting a glimpse of this, really work well together. And that's what makes this so impactful and why we need this service.
Delegate Kaufman.
Yes. I have a question. You said that overdoses are down like 60% or something amazing like that, right? So to whoever's best to answer, what do you attribute that to? It's a great statistic. I wanted to learn more about your formula for success.
So I would absolutely say, as Sue Ann was speaking with, our peers, our certified peer recovery specialists are integrated with our Sheriff's Department, EMS, local health department, and hospital. We are open 24/7. So trying to reduce those overdose deaths, not only we're saturating the county with naloxone, but we're educating family members on how to support and not enable those individuals. And we're ready to respond when that individual is ready for the recovery process. We make that happen in 5 minutes because if we don't, we might never see them again.
Thank you, Madam Chair.
Delegate Tavares.
Thank you, Madam Chair. So I just want to make sure I'm understanding it correctly, because when I started to see the numbers statewide of addiction going down, particularly, or deaths of overdoses on fentanyl going down, it was because they were sustaining their addiction with Narcan. So how much of it is preserving the addiction with Narcan versus getting off?
So what I will say is that's the same thing with naloxone distribution. When we distribute naloxone, if EMS wasn't recalled, it's not recorded, to your point, right? So technically, did overdose rates go down or not? Now, what I would like to say is that the fact that we are coordinating treatment for 50 to 85 people per month in our county of 107,000 people, we actually try to look at that scale and say that we're actually 100% making a difference. So to your point, I cannot tell you how many people have used naloxone on individuals and it hasn't been reported an overdose, but I'd like to think that we are absolutely here in Harford and Cecil counties.
I'm sorry, could you repeat that?
So to the fact that I cannot tell you how many, like let's say for instance, I overdosed and my friend back here, he reversed it and it wasn't being reported to EMS, which technically would not go in the record as a reported overdose, right? I cannot give you those numbers. What I can say is the number of reported overdoses have gone down, right? So to your point, are they sustaining it or not? I can't really give you those informations, but judging by that we're sending 50 to 85 people per month into inpatient treatment settings, is that I would like to look at that number as that we were helping heal Cecil and Harford County.
Thank you.
Thank you very much. Seeing no other questions, I just have a couple of questions. Obviously, the fiscal note is something that we have to address and understand. Of course. That said, I think this committee knows very well how beneficial these certified peer recovery specialists are and getting upstream. Getting people into recovery and maintaining that recovery. And I know that the department does cover CPRS services in licensed community-based substance use disorder programs. Delegate Hornberger, have you talked to the department about if there's a way to tailor this and pilot it? Because it seems their opposition is the breadth of the language.
Yes.
Because it makes it hard to know what the cost will be and also, what the cost benefit will be. We know the health benefit. Right. But have you had a conversation with the department to see if maybe there's a way to scale it, based on the successes of Harford County?
Yeah, what I would say is that from the research that I've done is when this was initially rolled out, this model, that it was supposed to be a 3-stage implementation, with the first stage being what at the time was called a methadone clinic and treatment services there. And then over time, it would go into the clinical setting and then even into the community and telehealth. It would be something that would just ubiquitously offered. Unfortunately, we never got past step 1, right? So what's happening is folks are sustaining their addiction. They're transferring it to another substance with Suboxone and the like, and they're continuing to have to go back to these clinics. And those clinics are profitable. We have ones that are operating in our community that are on a for-profit model, but we're paying for that, right? That's not captured in this fiscal note. If we can get someone to a point to full recovery, And I'll even go a step farther. We have folks here today that not only have had their recovery, but now they're working in the model and helping others. You can't put a tangible cost on that, right, of how much saving that is. So I think that we have to be able to have the courage to go and implement step 2 and step 3. Can it be in a phased approach where it's less of a fiscal note? Certainly. I mean, I'll leave it up to the wisdom of the committee to see if they can do that. And then additionally, the bill looks at how that model is delivered and convenes a task force and asks for feedback to us next year.
And I did note that as well.
Yep.
The call for the task force to evaluate how we could scale
Yeah,
this
and
up.
they did say, I believe, that they could do that in-house. Yep.
Yeah, I did see that. I'm going to ask you to stay involved with our committee because we can't be agnostic on the fiscal note, obviously.
Of course.
But there is an important initiative here. And to your point, we've already started that work. So let's see how we can continue to advance it.
The reality is, more often than not, many of these services that they're providing, they're just simply not being reimbursed for, i.e. they're doing it on a volunteer basis because they're passionate about it. All of these facilities are operating on a very, almost underwater every day. So to be able to get them to where they have sustainable funding, I think will really put a huge dent in the substance use disorder community. Thank you.
Thank you very much, and thank you for this bill. Seeing no other questions, this concludes the testimony of this panel. We do have another favorable panel and then a favorable with amendment. Dan Rabbit and Gary March.
Good afternoon, Chair Bagnell, members of the committee. Back up here by myself again. Again, for the record, Dan Rabbit, Policy Director at Behavioral Health System, Baltimore. Peer recovery services are essential to the continuum of behavioral health services that we provide in the state. BHSB has done a lot to promote their integration into programs across Baltimore, and we've helped to facilitate certification for aspiring peers to get that certification and that professionalism. We are big believers in the support that they can provide to folks who are seeking treatment and recovery. HB 886 would be a step in the right direction to expand peer services and help more people access this care. This is needed with the behavioral health workforce shortage that we have in the state. Right now, we have over 8,000 person frontline staff shortage in the state. And so accessing more insurance reimbursement for peer recovery services could help address that. Medicaid already pays for these services in the very specific SUD clinic setting that the delegate mentioned. And I just wanted to point out that that was a good first step. In the fiscal note, the department said that only cost $1 million. And my reading is 1 million total, so like 60% federal, 40% state. So the fiscal note saying it would cost $17 million, a 17-fold increase, seems a little high. BHSB agrees that like there could be some work here to be done to tailor it or phase it in. But improving and increasing the professionalism, or the professionalization rather, of peer recovery services and allowing them to access insurance reimbursement like all other behavioral health professions and services do would be an important step forward for integrating these important professionals into behavioral health treatment programs. So we urge the committee to give a favorable report.
Thank you for your testimony. Are there any questions from the members for this witness? Seeing none, thank you for your testimony. We do have a favorable with amendment. Oh, let me check one more time. Do we have Gary March here? Okay. Matt Kalina.
Thank you. Good afternoon, Chair, Vice Chair, and members of the committee. My name is Matt Kalina, and I lead an organization that supports people recovering from serious injury and trauma through peer connection and lived experience. I am here in support of House Bill 886 with amendment. Each year, more than 200,000 Maryland residents visit emergency departments because of injuries. For many, recovery does not end when they leave the hospital. In the months that follow, research shows that up to 1 in 5 injury survivors develops post-traumatic stress disorder, and nearly 1 in 10 develops major depression. Many also go on to experience substance use challenges managing pain. Peer support is one of the most effective ways to prevent that downward trajectory, but it works best when it comes from a trauma-informed, structured, and connected to the healthcare system, especially during the transition from hospital to home. For these reasons, I respectfully request an amendment to the definition of covered peer support services to include trauma-informed recovery services for individuals following injury and hospitalization, including services that are delivered through secure digital platforms, support care navigation, and an amendment to include outcome tracking and coordination with health plans and hospitals. This addition ensures that people recovering from injury are not excluded. It supports early preventative intervention, and it prioritizes high quality and accountable providers that promote accessibility. Including this in House Bill 886 will help Maryland move from reactive care to preventative. I respectfully urge your support for this bill and for language that reflects the full scope of modern trauma-informed peer recovery. Thank you for your time and leadership.
Thank you for your testimony. Are there any questions for this witness? Seeing none, thank you very much for your testimony today. This concludes the hearing on House Bill 886. And now we're going to move to House Bill 739. This is health insurance prompt payment of claims requirements. Delegate Martinez, if you want to approach the table and bring your panel, and you can get started when you're ready.
Okay. Good afternoon, Madam Chair and members of the Health Committee. For the record, I am Delegate Ashanti Martinez, here to present House Bill 739. At its core, this is a simple bill, but it fixes a very real problem inside Maryland's healthcare system. When a patient goes to a doctor, therapist, clinic, or hospital, care happens immediately. Payment does not. Right now, our insurance claim process allows for claims to sit in administrative limbo. Not approved, not denied, just stuck. Providers are often not clearly notified what information is needed or even that additional information has been requested. Instead, they are told to log onto a portal and search for individual claims one at a time. A slow, manual process that frequently provides very little explanation. And while the claim sits in a pending status, no one gets paid. House Bill 739 fixes that communications failure. The bill requires insurers to affirmatively notify providers by mail or email about the status of a claim and exactly what information is needed to resolve it. It also establishes clear timelines. And if additional information is requested, the provider has 30 days to respond, and the insurer must then pay the claim or issue a denial. Why does denial matter? Because the denial gives providers rights. It allows them to appeal, correct the claim, or resubmit. Right now, when a claim is simply pending indefinitely, providers cannot access Maryland's appeals or grievance process. Colleagues, this is not just an administrative issue, this is an access to care issue. When providers are not paid on time, small practices in particular, such as behavioral health providers, community clinics, and safety net providers, absorb the financial strain. Hospitals and practices are forced to spend staff time chasing claims instead of treating patients. And when providers cannot sustain operations, appointments disappear, networks shrink, and patients cannot wait longer for care. We spend a lot of time in this committee talking about workforce shortages, but sometimes the workforce problem is not merely education or recruitment. Sometimes it is whether providers can keep their doors open while waiting months to be paid for care that they've already delivered. House Bill 739 does not change reimbursement rates. It does not create a new mandate. It does not favor providers over insurers. It simply creates clarity, communication, and closure. Providers will know what is needed, insurers will have defined timelines, and patients will benefit from a more stable healthcare system. This bill is about predictability and fairness in the claims process, ensuring a system built to pay for care actually functions in a timely and transparent way. For those reasons, I respectfully request a favorable report on House Bill 739.
Thank you, Madam Chair, members of the committee. I'm Jake Whitaker, and on behalf of Maryland's hospitals and health systems, here to testify in support of House Bill 739. So as Delegate Martinez outlined, this is really about when those claims are in limbo. So as you know, claims can be reimbursed by a payer, they can be denied by a payer, but oftentimes they are pended basically to ask for additional information to be able to, in all fairness to the insurance companies, be able to make those determinations. That said, this bill will help kind of create a more functional process that's more predictable for providers. So what this bill will do is it requires insurers to clearly explain what they need, not hide behind a provider portal. So right now, we'll ask for information, and they won't tell us what we need. They'll direct us to a portal instead of just telling us exactly what they need. So when insurers actually spell out what's missing, we can respond quickly and resolve those claims and reduce out-of-pocket costs for your constituents. This also reduces the amount of staff time that's wasted working with insurance company and addressing those different billing issues. And just to kind of outline, under the current rules, insurers can pend a claim indefinitely, basically essentially avoiding the payment or making a decision on that claim. So this bill really helps force that issue. So if the insurer needs more information, they need to ask for it clearly. If the provider doesn't respond, the payer must deny so that this claim doesn't just stay stuck. They can start the appeals process. And for us, it's really kind of, as you know, we don't like denials, but at least it gives us kind of a place to move forward with and start that appeals process. So it allows us to start those appeals, it allows us to correct those claims, and it gives us a pathway forward to actually resolve them. So while a denial is not ideal, it does give us the opportunity to be able to address it rather than just kind of waiting or trying to figure out or guess what the insurance company wants. So for the aforementioned reasons, we respectfully request a favorable report on this bill. Thanks.
Good afternoon again. For the record, my name is Dana Kaufman. I'm here again on behalf of MedChi and the American College of Emergency Physicians. We are also in support of House Bill 739 and request a favorable vote. It's interesting because for the last several years, we focused mostly in this committee on utilization review requirements. But I think you're seeing a theme now. You heard a bill earlier this year. You're going to hear a bill later this session. And they're really focusing on the payment issues and the prompt pay. And one of the main reasons is ensuring that the physician practices are financially viable. And when we don't get paid on time or our claims are denied in part without the ability to go back in a timely manner, that does hurt physician practices. And Maryland is losing our independent physician practices. The most recent report of the Maryland Healthcare Commission showed that over the last 5 years, we've lost 45% of them. So I think part of these bills are trying to shore up the processes that are already in place. We do understand that there is some need to clarify some of the provisions to close a loop from drafting, and we're willing to work, but we really are just trying to make sure that the physician offices have the necessary protections and that billing can be done with certainty and on time. Thank you.
Thank you for your testimony. Are there questions from the members for this panel? Vice Chair Cullison.
Thank you, Madam Chair. And thanks for bringing this to our attention. So my question is, are there a set of timelines already set in law, and is there a timeline from the time the provider makes the claim to the carrier, and then how long does the carrier have to respond? I mean, I understand the concept of the pending, so that I do understand, but I'm wondering if there's a timeline already set.
I can respond. So after receipt of the claim, I want to try to do this by memory. After receipt of the claim, the carriers have to do certain things. So I think it's within 30 days, they have to either pay the full claim or they have to send notice to the provider that part of the claim is in dispute. Okay. If part of the claim is in dispute, then they still have to pay the undisputed part of the claim.
And for the claim that is in dispute, they also have to request whether or not additional information is necessary. And then there's another area that if they don't think that the claim is clean, they have to request the information to make it clean. And that all has to be done in 30 days. So I think what this bill is trying to do is make sure that there were additional timeframes put into place, so that is not a unending loop. So claims are getting paid after additional information is being submitted, but also making sure that it is very clear what additional information is being requested. We did similar language when we did the prior authorization bill as well, as it related to, I'm trying to remember, if you have to ask what additional information is necessary with specificity if you are not going to, when you are reviewing a claim that needs a prior authorization.
Are you saying that the payers are not meeting these timelines now? Is that what you're saying with this bill?
Yeah, so I think under the law, there's existing timelines for the prior authorization process as well as for the reimbursement and denial process, but there's that third piece for pending claims. So there's currently no statutory timeline, and that's what this bill does. It imposes that timeline.
So so let me just play this out. Seriously, I'm just trying to figure it out. So the payer says, oh, we need more information. And the information they requested is supplied. Does that then kick the 30-day window? Because what I heard was they had 30 days to respond to a claim. So does it click the 30-day window again?
So my understanding is that we're not getting that information. We're being directed to a provider portal instead of just being told what they need. So our concern is that, one, they need to tell us what they need within a certain period of time, or it becomes a denial, or, you know what I mean, then it becomes a denial process, or they just need to tell us what it is, and that's the problem.
So I'm looking at the law right now, our law, and it says that the claim is not, if the payer says the claim is not clean, and the specific additional information necessary for the claim to be considered clean claim has to be submitted to the provider. So the law already states that it has to do that. So you're saying they're not meeting those requirements now?
So we will provide the information when they ask for it. I think it's the timeline that they need to, that basically becomes a denial. That's the issue. So like, for example, if we don't get the information we need, or they don't request the information from us, and they don't give us the tools we need to be able to respond with that information, then that 30-day clock kind of creates a denial, and then we can move on to the appeals process. So that's what we're trying to do.
So you're saying after, I'm sorry, Madam Chair, just real quick.
It's your subcommittee.
Right, right. After the second 30-day period, so after the information's been submitted, the new information, the completed information's been submitted, you're saying that they don't adhere to that next 30-day window?
So I'd have to double check, but I believe that's a clean claim at that point because they have all the information, and then the 30-day clock for reimbursement starts then.
Right, that's what I was thinking. Okay. Thank you, Madam.
Delegate Hill. Thank you. Delegate Martinez, thank you for moving this ball a little bit further down. The Maryland Psychological Association asked for an amendment that specifies that you can actually use snail mail if that's the preference. You're good with that, right?
Yeah, I'm fine with whatever the provider's preference is.
Thank you. And can I have a follow-up? All right, Ms. Kaufman, did you have anything to add to the Vice Chair's questions about whether a pending, what are the circumstances around why they would say it's neither denied nor paid, it's just pending, and what those timelines look like? Did you have any other additional information what this pending claim looks like?
I think that the concern, and I know that the language of the bill does need to be clarified a bit to tighten that up. But I think what we're trying to do in the bill is to create a bit more certainty for the timeframes so that there is a point where that loop gets closed, which I also think is important that there was some language in about not paying as a denial. Because that would bring in appeals and other protections as well. But again, I think that this is also needing to take into account some other bills that you're going to be hearing about later in the session as well. That just all goes to the billing of claims and then the payment of claims.
My question has been answered.
Thank you very much. Seeing no further questions, this concludes this panel, and I believe this bill hearing on House Bill 739. So we are going to go to House Bill 633. This is Health Insurance Ovarian Cancer Prevention with Salpingectomy, Required Coverage and Prohibited Cost Sharing. Delegate Hill, if you want to. Salpingectomy? And Delegate Hill, if you want to bring your panel up, and you can start your testimony when you're ready, and then I can hear how it's actually pronounced.
And members of the committee, for the record, I'm Terry Hill, and I'm presenting HB 633. Thank you. And I urge a favorable report. Thank you very much. No. So salpingectomy is removing the fallopian tube, right? The tube that connects the ovary to the uterus and through which fertilized egg has to travel in order to implant in the uterus and for a normal non-ectopic pregnancy to take hold. It has been found that ovarian cancer often starts in that tube, the fallopian tube, and that under certain circumstances, such as if you have markers that put you at high risk for ovarian cancer, removing that tube can be preventive to preventing ovarian cancer, which is the deadliest form of GYN cancer. And that's for any number of reasons. In fact, here in Maryland, on average, as you've seen, I don't know if it's in the testimony or somewhere else, about 270 women a year in Maryland are diagnosed with ovarian cancer. And 69% of those women are diagnosed at an advanced stage. Salpingectomies are covered by insurance under certain circumstances. So if the tube is blocked and the fertility or infertility treatment is covered, it's covered. If there's an infection in the tube and you have to remove it for infection, it's covered to remove that tube. What's not covered is if you're taking it out just because, I say just because you're trying to prevent ovarian cancer, because the patient has the BRCA markers, and they're at high risk for ovarian cancer. So as some of you know, with certain markers, patients may elect to have their breasts removed so they don't have breast cancer. They may elect to have their ovaries removed so they don't get ovarian cancer based on family traits and markers. Salpingectomy is one of those things that can be preventive for ovarian cancer. The most common time that the surgery is done is if the surgeon happens to be doing another surgery. So if you're in there doing the gallbladder, you're in there tying the tubes, then rather than tie the tubes, removing the tube would be a way to prevent or diminish the risk of getting ovarian cancer. And what this bill would require is that that be a covered service, that prophylactic, meaning protective, preventive, anticipatory removal of the tubes, particularly as an incidental, be covered. Now, let me also explain sort of how reimbursement works with most insurance companies when it comes to doing multiple procedures on the same day. So if I'm already, if I'm doing, a gallbladder, or I'll give you a more common example. I've gone in to do an exploration of your abdomen because you've presented with some symptoms, and I'm concerned that you have a bowel obstruction or something I have to go in and fix. I may go in and do that surgery, and it is pretty common practice that if I'm there anyway and the scar might confuse a future diagnosis of abdominal pain, to go ahead and take out the appendix. It doesn't add but 5 minutes to the case. You can take out, it's called an incidental appendectomy. The appendix wasn't ill, the appendix wasn't diseased, but we're taking it out because we don't want anyone to get confused in the future if you have pain in the abdomen and they think you still have your appendix. And so the patient's informed, et cetera. The insurance generally, at the reimbursement level, they either don't cover it or they cover it at very little, because when you do your primary procedure, that's paid at whatever the so-called negotiated rate is. And any secondary procedures are paid at significantly less. The idea being, well, you're already under anesthesia, you already have to be seen for postoperative care, so we don't have to cover that at the full value if you were doing that thing. So when we talk about covering salpingectomies, we're not saying that the surgeon takes it out and then bills for some full procedure. If it's reimbursed at all, it's going to be reimbursed at a much lower level. What we're trying to do is say that this has been shown to be preventive for ovarian cancer. We want to prevent cancers, not wait until patients get them. And that if it's indicated either because of gene markers or for other reasons to take out the tube, then it ought to be something that can be billed for and covered at a reasonable rate. And I think that's the essence of the bill.
Good afternoon, Madam Chair, Madam Vice Chair. My name is Dr. Erin Wright, and I'm here before you today not only as a doctorally trained certified nurse midwife and an assistant professor at Johns Hopkins School of Nursing, but also, and perhaps ironically, as a high-grade serous stage 3C ovarian cancer survivor. I am representing both the American College of Nurse Midwives, Maryland affiliate, and the Ovarian Cancer Research Alliance to express my strong support for House Bill 633 that mandates insurers, nonprofit health service plans, and health maintenance organizations to provide salpingectomy coverage for ovarian cancer prevention without imposing any financial barriers such as co-payments, co-insurance, or deductibles. Ovarian cancer, despite being the most lethal of the gynecologic cancers, is often referred to as a silent killer because its symptoms can be subtle and easily overlooked. Back pain, heartburn, feeling full. With only 30% of individuals diagnosed with my same stage of cancer surviving 5 years or more, I know all too well the harsh realities and devastating impact of this disease. I reached the 5-year survival mark in 62 days. But 70% of my peers will have not. I am privileged in every way, but despite my clinical knowledge and experience, I could not prevent my own cancer. Approximately 20,000 women in the United States will receive this diagnosis each year, and too many lives are cut short by a cancer that could have been mitigated through preventive measures. Salpingectomy, removal of the fallopian tubes, has been shown to lower the risk of developing ovarian cancer by up to 50% in high-risk patients. Yet even with these proven benefits, the financial burden of this procedure often deters women from seeking it, women like my 2 girl children. This bill would empower women to take proactive steps for their health without the looming threat of financial strain. This is especially crucial for women in marginalized communities who already face significant barriers to accessing health care. By prohibiting co-payments, co-insurance, or deductibles on salpingectomy coverage, we ensure that all women, regardless of their socioeconomic status, can make informed medical decisions without financial barriers in concert with their physicians. Thank you.
Thank you for your testimony, and you do have 2 virtual witnesses on your panel.
Please.
So let me, do you want us to start with Eileen O'Neill?
Yes, please.
If you could unmute and begin your testimony.
Good afternoon, Madam Chair and members of the Health Committee. I'm Eileen O'Neill, here to testify in support of HB 633. I'd like to thank the delegates Hill, Kaufman, and Terrassa for sponsoring this life-saving legislation. I'm a longtime Maryland resident and former group president of Discovery Channel and TLC cable networks. Like millions of women, I thought the annual GYN exam was able to take care of any and all gynecological concerns, but it turns out they can't screen for everything. And 3 years ago, I didn't know anyone with ovarian cancer. That is until my wife was diagnosed. It's been an incredibly difficult time for my wife. This is a horrible disease which requires significant surgeries and chemo just to extend a quality of life worth living. I was told ovarian cancer doesn't just happen to the woman, it happens to the family. My wife, our son, and I would not wish this disease on anyone. During my wife's first year of treatment, I learned most women are diagnosed with advanced disease because there is no screening, and more devastating, there is no cure. So when I heard you could prevent this horrible disease with a minor procedure, I said, yes, please. I learned about salpingectomy and, equally important, learned how to pronounce it. My path to salpingectomy included genetic testing, which revealed I had a higher risk of getting ovarian cancer, making getting a salpingectomy a no-brainer. Here's the real kicker. Post-surgical pathology revealed a precancerous lesion in my left fallopian tube. I was a ticking time bomb for ovarian cancer. Think about that. If I had not had a salpingectomy, there was the enormous chance I would have ovarian cancer by the time I turned 65. Every woman in Maryland deserves the right to prevent this disease for herself and protect themselves and their families from the physical, emotional, and financial cost it inflicts. Salpingectomy saved my life. Please help save others. Thank you.
Ms. Stone, if you want to go ahead and unmute and begin your testimony.
Yes, thank you. Good afternoon, Madam Chair and members of the committee. I'm Becky Stone, the head of GYN Oncology for Johns Hopkins. And as Dr. Wright pointed out earlier, ovarian cancer is the silent killer. The moniker is fitting because most women who develop it have no known risk factors or even any obvious symptoms. For decades, billions have been invested in developing a screening test, and we still do not have one that works. So ovarian cancer is typically diagnosed at an advanced, incurable stage when even the most cutting-edge therapies only extend life a few months. The average cost of care for one woman exceeds $1 million, and in Maryland, a woman is diagnosed nearly every single day. But finally, a scientific breakthrough has given us a decisive advantage over the silent killer. We now know that the most common and deadly forms of ovarian cancer do not actually begin in the ovary, but rather in the adjacent fallopian tube. And this discovery changes everything because population-level prevention for all, is now possible. Removing the fallopian tubes, commonly called salpingectomy, can cut the risk of ovarian cancer by nearly 80% for all women, regardless of genetic markers, family history, and other risk factors, and these data were just published in JAMA last Monday. Salpingectomy does not remove the ovaries, so it does not cause menopause. Because salpingectomy offers the dual benefit of permanent contraception and cancer prevention, it is now the standard of care alternative to tubal ligation. It is already standard at hysterectomy and now can be safely incorporated into other post-reproductive abdominal surgeries, adding only minutes and minimal cost. We are standing at a rare moment in medicine, an unprecedented chance to outsmart a disease that has outsmarted us for far too long. But prevention only works if people can access it. And if we act, Maryland can lead the nation in aligning policy with recommendations from ACOG and new coding from the CDC. Thank you.
Thank you for your testimony. I'm going to open it up to our members of, Delegate Hutchinson, followed by Vice Chair Collison.
Thank you, Madam Chair. Thank you, Delegate. You may have mentioned this at the beginning, and I just want to understand, if a woman has the BRCA gene or has a family history of breast cancer, can she elect to have a double mastectomy, and that's paid for by insurance?
I believe it is paid for by insurance, but I'm not sure. Maybe one of the other witnesses can answer that.
That is my understanding.
So would you say then this is under that same vein of preventative cancer?
I think so, but let me just read from the letter from the Department of Budget and Management. And they point out that salpingectomy has not been classified as a preventive service, but mastectomies have been. So it may be that that's the distinction, and therefore it would not be covered under the Affordable Care Act because it's not classified. You just heard testimony that we now have evidence And so you can ask another question of Dr. Stone here. That evidence may be sufficient to then move to, there is now evidential thing to make it considered a prophylactic thing. But that may be the distinction that they're going to fall back on, is that one is considered to be proven to be prophylactic and the other one is not.
Maybe one of my colleagues will ask that second question,
And you
but
don't think
I need a clarification. Are you looking at this as it's a secondary procedure that will occur because of a procedure, or somebody just might want to elect to have it?
I think we're looking at both, but certainly if it is, if to move the bill along, we've got to go in steps. And we first move those who have genetic markers or who have strong genetic predisposition. But you've heard it's 80% effective regardless. And then we move to, if it's on a secondary procedure where it's very little cost, the anesthesia's already there. And then we move to, electively, I just need to have this done because I'm concerned about it, even though I don't have markers. I'm certainly open to that, but right now, it's just not covered.
Thank you.
Thank you. Delegate, so Vice Chair Cullison, followed by Delegate Gazzoni.
Thank you, Madam Chair. So, Delegate Doctor and your colleagues here. So I'm still uncertain as to what the initiating event would be that would where a physician would advise this. I mean, what would, I think I heard one of your witnesses say that there was something specific that was noticed and that.
Let me ask Dr. Stone to answer the question.
Okay.
Yes, thank you so much for this question. So essentially what we're talking about is that the risk is simply being a human with fallopian tubes. We have really no way to identify most women who are at risk for getting this disease. Family history misses, a large number of women who will ultimately go on to get ovarian cancer. And to find out that you have a genetic predisposition to ovarian cancer only after your cancer diagnosis is probably the biggest failure of preventive medicine there could possibly be. So we are talking about covering salpingectomy as a preventive service for all women with fallopian tubes. And, when you think about people who are average risk, so seemingly average risk, meaning they have about a 1 in 100 to 2 in 100 chance of getting the disease in their lifetime, those folks are the folks who might consider having a salpingectomy instead of a tubal ligation when they're done having kids and they're interested in permanent contraception. If they're having a hysterectomy, they can have a salpingectomy at the same time the uterus is removed. Or if they find themselves having any post-reproductive surgery on the abdomen, like a cholecystectomy or a hernia repair, having fallopian tubes removed at that time. So it's done opportunistically when the surgeon's already there anyways. For women who are higher risk due to genetic or family history, those women, because of family history or a positive genetic test that indicates increased risk, would be approved without cost sharing for a standalone salpingectomy. And so those are the differences. It's based upon risk. And the CDC has recognized this as a preventive service for all women, both in the high risk category and in the average risk category, and has provided ICD-10 coding to cover these care episodes. And these went live October 1st.
Thank you, Madam Chair.
Delegate Gazzoni.
Thank you, Madam Chair. Okay, probably going a little into the weeds here, but I'm curious. So it sounds like there's two different sort of chunks of this. There's the opportunistic and then essentially non-opportunistic, where you're just doing this because you want to get it done. If it's opportunistic, does insurance cover that currently?
No.
Not at all. So if you're having tubal ligation and you get this done and it's a separate charge that's not covered by insurance. Okay, that's part one. Can I keep going on? Just thank you. My second question, and I'm not sure who the best person is, and it may not be any of you. I relatively recently had a colonoscopy, which is absolutely preventative. It prevents cancer. My doctor told me that the first time I got one. And yet I pay a copay. So I'm just, if we're splitting up the chunks of this bill, looking at the zero copay piece of it, just popping that out there, that there are other cancer preventative procedures that many, many, many people have, and everybody is suggested to have after whatever age it is now that I have passed. You're paying a copay for that, so.
Can I ask you a question in return about the copay? Was the copay for the procedure itself, or was it for related services like anesthesia or pathology, or both?
I don't actually know. It was the facility that I went to, they billed me.
Yeah. So I think
a couple
you got
times actually, but sure.
fee. I think you got a facility fee, and that's what you were required to pay a copay on. But the procedure itself, my guess, the colonoscopy, I'm guessing should have been covered according to the Affordable Care Act as all preventive services, and salpingectomy should fall under that because it's also, doubles as a pregnancy prevention service, for people who are under the age of 65. But I ask this because we have seen, when you ask, is this covered by insurance? We've seen so much variability in working with the National Women's Law Center in DC about coverage of this, even as a form of birth control, as an alternative to tubal ligation. And in many cases, women will, the procedure like a salpingectomy or tubal ligation will be covered, but then they get a copay or cost sharing for anesthesia or for pathology or for a facility fee.
Delegate Tavares, followed by Delegate Morgan.
Thank you. I'm just trying to gain a little bit of clarity between this procedure and the hysterectomy, which is the removal of the uterus. And it seems that the reason why, based on my quick Google search, is that, sorry, that hysterectomies are for like fibroids and your uterine cancer and endometriosis and such, while the other one is maybe not so clear. But hysterectomies are covered by insurance.
Correct.
For those reasons. Are there any other reasons that people may want to do that may be more similar to the same issues that we're grappling with the ones that you're proposing today?
I'll defer to Dr. Stone.
Yeah, absolutely. That's a fabulous question. So for prevention, as a GYN oncologist, we provide hysterectomies to women all the time. So we know women who have a BRCA1 genetic mutation who are a very high lifetime risk for developing tubo-ovarian cancer, really tubal cancer, but call it tubo-ovarian, I suppose. Also have an increased risk of very risky types of endometrial cancer. And so we often will offer women a hysterectomy for prevention in that situation. And there are a number of other genetic conditions that increase the risk of uterus cancer, endometrial cancer, where hysterectomy is provided as a cancer prevention service.
Okay.
Delegate Morgan.
Chair. My question is for the doctor on the panel. I obviously don't have any fallopian tubes. This is the first I've ever heard of this type of surgery. Can you give me some comparison, just for really personal knowledge? I'm trying to reconcile this. What is the cost of some type of elective procedure to have this done? And what kind of recovery time is there for the patient?
Yeah, thank you for asking that. So, when this is done opportunistically, which is, really what we're talking about, that's the most cost-effective scenario to do this in. And there have been a number of cost modeling studies, published cost modeling studies around this, for the U.S. One of them shows that, by creating universal access to salpingectomy when a woman's having a hysterectomy or as an alternative to tubal ligation in the United States would prevent almost 2,000 cases of ovarian cancer every year and save $500 million healthcare dollars. And that's just because it's so expensive, to provide care to even just a single woman with this disease. And then, something like 90 cents on the dollar is spent, it's still in caring for somebody who will ultimately die from that disease. Whereas when you think about the cost of this, especially done opportunistically, when, person's already going to the OR for some reason, like a tubal ligation, and they switch it out to a salpingectomy or a hysterectomy for fibroids, they can have a salpingectomy for prevention, or, a hernia repair, they can have their tubes out, takes 5 minutes. We're talking about the cost of a domestic airline flight. And so, very, when you look at the cost effectiveness around this, most analyses almost indicate that it's cost saving, really. It's just a long return on investment, right? We have to invest now to save people's lives, in the future. It adds about 5 minutes to the already ongoing surgical procedure, and it doesn't change recovery. And woman, importantly, doesn't go through menopause, because now ovarian cancer prevention is not predicated on ovarian removal, but removal of its true most common source, the tube.
Just a point of question. So again, for women that choose to do this as a standalone procedure, what would the recovery time be?
Typically most women are recovered after about, 2 weeks, but you can probably ask Eileen because she had one done.
Okay.
Yeah, just it was really remarkably easy. 2 or 3 days of Tylenol and ibuprofen, and then just couldn't be on the golf course for about 3 weeks. But you're walking around, you're doing things, and that was it. And P.S. minimal scar.
Okay. Thank you, Madam Chair.
May I offer a statement?
No,
to the
we've been given a lot of leeway today because I think we all want to understand salpingectomy.
Yay.
So I'm not going to be pronunciation shamed. It's fine. I don't see any more questions from our committee for this panel. We do have one more favorable panel. So thank you very much for your testimony.
Thank you very
and we have Christine Crone.
Madam Chair, I was just written testimony, sorry. Thank you.
My information was incorrect, so thank you very much. That actually concludes then the hearing on House Bill 633. We're going to move to House Bill 737. This is Health Maintenance Organizations Payments to Non-Participating Providers Reimbursement Rate. Delegate Hill, if you want to bring your panel and get started. I did get a note just for your edification that Mr. Shattuck is not available. I guess he's maybe over in the Senate.
Okay. I think it's going to be a very exciting hearing as compared to the last one.
So you can get started with your testimony.
All right. So let me just sort of set the background. We know we've got in-network providers, right? People who insurance companies contract with, agree on a certain set fee for certain kind of procedures and things to happen, certain kind of care. And then we've got out-of-network providers who are not part of that network, are not under contract, may provide care. We've got in-network facilities where insurance companies have contracts and we'll tell patients if you're going to have it done and you want us to pay, you've got to go to this facility. And then we have out-of-network facilities where you might decide to go, but the most common reason you would go to an out-of-network facility is if you have an emergency, right? So you have an emergency, you don't necessarily get to control where you're going to end up. It might be up to the ambulance, it might be up to how sick you are, but you're going to show up somewhere. So back in 2020, Congress passed the No Surprise Act, no surprise. And essentially what the No Surprise Act did in an effort to save patients from being surprised by bills they hadn't anticipated is say, if you're in an in-network facility and your care is being provided by an out-of-network provider, that provider can't balance bill you for what your insurance company doesn't pay them. So out-of-network provider, that has no contract with the insurance company, because remember, the insurance contract is between the patient and the insurance company. So if you're an out-of-network provider, you haven't made any deals with this insurance company about what you're going to do. So you show up to the emergency room, or you're in the emergency room if you happen to be an ER physician or what have you, and you show up, you provide the service. And this first part of the bill was like, you got to tell the patient before you do the service, what's it going to cost me? So if they call the plastic surgeon in, and the plastic surgeon's going to sew you up, the plastic surgeon's supposed to say, I'm going to charge you on this, and I don't take your insurance. So if you really want me to be the one to do this, you need to be prepared to pay this. Or if your insurance will cover it, there may be a big gap between what the insurance considers the appropriate fee to pay and what I'm charging, and you're going to be responsible for that. So before the No Surprise Act, that's kind of where things were, and you were balanced bill the difference between what the insurance was going to pay and what the actual fee was. Okay? But the No Surprise Act said that you can't balance bill a patient. So you're coming in as the emergency caregiver, the orthopedist who's coming in to fix a thing or take the person to the OR emergently, and you have to take what the insurance is going to offer, which frankly, if it were a reasonable amount, you'd already be in network, right? You'd have agreed to do that. And you came in emergently, but you don't get your full fee. You're the one that eats it, not the insurance company. The patient has no part of it, and that's essentially what it is. So again, idea of saving patients money, and more importantly, not letting them be surprised about situations that they can't control, because, it's an emergency. That's why it was passed, but what some entities like the HMOs did is they said, well, okay, we're going to stop having paid emergency room people. We're not going to do a contract with the emergency room providers. We're not going to do a contract with the radiologists. We're not going to do a contract with the anesthesiologists. And if you end up in a facility we have this agreement with, then we don't have to pay you close to your fee. Our patients don't have to pay the balance, and we can pay you what we pay someone in network, so we get the advantage of your services on an emergency basis in network without paying you for the reality that you're out of network. Okay? So this bill is trying to address that. And that's kind of it in a nutshell.
Okay. Go ahead, Dr. Brown.
Good afternoon, Chair Bagnell, Vice Chair Collison, and committee. I'm Reginald Brown, practicing board certified emergency physician. I'm a board member for the Maryland chapter of the American College of Emergency Physicians and a member of MedChi. Last night I was doing what I do best, caring for patients in Aberdeen until about 6 a.m. So please forgive my fatigue and maybe a little bit of frustrated tone this morning. I'm frustrated with how difficult it is to reach a common sense solution. I get that national politics no longer supports or respects scientists and doctors. We question vaccines and global warming. I hope that sentiment is not leaking into Maryland. It was not long ago that our emergency department colleagues were hailed as healthcare heroes. I hope that deference to expertise still exists in Maryland. Bill 737 supports fair reimbursement for hospital services, including emergency services. For 17 years, USACS legacy groups were in network with Kaiser. What changed? Well, the NSA came through, and we continue to we never balance billed, or we're in a general practice, we never balance billed. And we continue to stay in network with over 90% of payers. We say the health insurance colleagues will suggest that slashing payments has no impact on patient care or outcomes. I know firsthand that access to care in our Eastern Shore, Calvert County, Harford County is impacted by these payments. Recruitment is impacted, wait times are impacted. Last year in this chamber, now Speaker Panamelik urged us to reach compromise. We met pre-session, and we even offered a Virginia compromise to our insurance colleagues. In Virginia, they're receiving about twice the reimbursement that we're receiving in Maryland. We have yet to hear back. In the absence of legislation, it's going to be increasingly difficult to bring the insurance colleagues to the table, and I don't fault them. It's not a good business practice for them when there are no levers to bring them to negotiate. Thank you.
Thank you, Dr. Brown. Thank you, and good afternoon, Madam Chair and members of the committee. Caitlin McDonough on behalf of U.S. Acute Care Services and in coordination with emergency department physicians in virtually every hospital in the state. We're here in support of House Bill 737, and thank you to Delegate Hill for her leadership and explanation on the bill. And you may recall from previous years on this bill and others, how HMOs and PPOs different. And one of the differences for HMO is that key tied to preferred in-network providers. However, when virtually all emergency care providers in the state are out of network with no realistic path to in-network status, the out-of-network rate is the reimbursement for those services, and it has a direct impact on patient ability to access quality and well-staffed emergency care. If all our emergency physicians are under-reimbursed compared to historic rates in the state and neighboring regions, it creates a severe staffing challenge and results in overextended care and longer patient wait times. While the No Surprises Act creates certain financial protections for patients, the use of that law to revoke in-network emergency services that is frequently accessed by those patients absolutely impacts them, and we're looking for a solution. Our solution of choice would be to reopen negotiations so we can get in-network status or back to where we were, because that's the preferred provider model that we know works best for patients. If that continues to not be possible, as it is for virtually all emergency physicians in the state since 2021, a public policy baseline is our only path forward. The solution in the bill is tied to the 2019 rate, which coincides with the enactment and basically the outcome of the NSA, but we're open to other solutions, and I'll thank the Vice Chair for bringing us together prior to the session to start to vet some of those. But the rate has to be something that's going to be adequate. We have adequate care, patients have adequate access, and we're not bleeding talent over state lines to DC and Virginia. So we urge a favorable report and happy to answer any questions. I know there's some interactions between state and federal here, and happy to answer any questions about what's going on in Maryland.
Are there any questions from the members for this panel? Seeing none, thank you very much for your testimony. I do have one information witness, Lindy Burns, and then an unfavorable.
Okay. Hi, good afternoon, Madam Chair and members of the House Health Committee. I'm grateful for all the work you do and grateful for friendly, familiar faces. My name is Dr. Lindy Burns. I'm a licensed acupuncturist in Maryland, and I'm also the president of Maryland Association of Acupuncture and East Asian Medicine, and I work closely with our insurance committee and billing professionals across the state. I'm currently undecided on House Bill 737, finding that there is insufficient clarity regarding the impact of raising reimbursement rates for out-of-network providers without simultaneously addressing the stagnation of in-network reimbursement rates. In-network acupuncturists across Maryland are struggling to sustain their practices under reimbursement rates that have remained largely unchanged for over a decade. These rates have not kept pace with inflation, practice overhead, or the rising administrative burdens imposed by carriers. Acupuncture is an evidence-based, cost-effective intervention that reduces reliance on high-cost pharmaceutics, decreases surgical utilization, and improves recovery outcomes when surgery is necessary. These outcomes generate measurable savings for insurers and improve patient well-being, yet reimbursement structures do not reflect the value acupuncture brings to the healthcare system. Raising out-of-network reimbursement may lead in-network providers to leave network, which removes contract agreement and impacts their ability to renegotiate reimbursement rates. We've also prepared testimony for House Bill 790 5 in strong support and will gladly come out, hopefully when that comes back to the floor. Thank you for your time and leadership. My colleague Laura Figge and I are available to answer any questions.
Thank you for your testimony. Are there any questions for this witness from the members? Seeing none, thank you very much for your testimony. We do have an unfavorable panel, Allison Taylor and Matthew Celentano.
Good afternoon, Madam Chair, members of the Health Committee. Good to see you again. My name is Matt Celentano, here today on behalf of the League of Life and Health Insurers in opposition to House Bill 737. This legislation wouldn't do anything but raise costs to consumers with zero benefits to them. It won't improve care. It won't streamline coordination. It purely picks winners and losers in how they are reimbursed by HMOs. The irony of this discussion is that when it was offered by the ER docs and the MHCC analysis from a few interims again show that they actually fare worse under this proposal. The whole point of an HMO product is that a consumer accepts a narrower network with the same rich benefit structure that you would get in a PPO product. This legislation threatens that choice for consumers. The MHCC work also supports this. HMO products by design to create affordability have narrower networks. As you all know in this committee, the No Surprises Act in Congress was passed to prevent providers from balance billing consumers for services provided in out-of-network situations. This bill seems to want to reverse engineer that consumer protection law by indexing the reimbursement rates to 2019, which was prior to the No Surprises Act. No Surprises was a bipartisan piece of legislation, that's shocking on its own, that everyone supported, that holds patients harmless from balance billing. This bill is an end around on a significant piece of legislation from Congress to protect unknowing patients, and the impact of this legislation would result in higher bills for consumers, increased premiums, as well as disincentivizing provider groups to join HMO networks. Thank you for the opportunity for the committee, and we urge an unfavorable report on House Bill 737. Thank you.
Good afternoon, Madam Chair and members of the committee. My name is Allison Taylor. I'm here on behalf of Kaiser Permanente, and I do want to thank Ms. McDonough and Dr. Brown for some good conversations that we've had. Kaiser Permanente's commercial plan and Medicaid are among the top 5 rated in the country for patient outcomes, and we do attribute that to our really tightly controlled network strategy, where about 95% of services are performed by the 1,800 physicians that exclusively see Kaiser Permanente patients. The rest of our network is based on the gaps that we have there. We experienced, and so did payers across the country, a pattern before the No Surprises Act where certain specialty types, including ED, things like anesthesiology, would threaten balance billing our members if we didn't accept exorbitant rates. You don't take my word for it. You can ask the Federal Trade Commission that's been investigating this. So Kaiser made a business decision before the No Surprises Act to pay some very high rates to proponents and others too, not just them. When the No Surprises Act passed and the market conditions changed, they did choose to make a different go in a different direction in the ability to offer lower rates to their members. Another concern I want to flag for you with this bill is that as currently drafted with the 2019 date, it would have, some physician specialties would be winners under this and probably see higher rates. I'd say the proponents are among them. Others who didn't have this dynamic with the No Surprises Act would probably see lower reimbursement, since reimbursement for them has continued to go up over the past few years. So anyway, that's where we're at. We do urge an unfavorable report on this bill. Thank you.
Thank you for your testimony and your timing. Do we have any questions from the members for this panel? Delegate Hill.
Thank you. And thank you, Allison, for the conversations. So we heard testimony that you all are not interested in negotiating, or you're not interested, you have not been able to move forward on negotiating what you would each consider a fair reimbursement level, and that emergency room out-of-network providers in Virginia are getting significantly more, and the Maryland providers have asked for something similar. Can you talk to us about what you're paying folks in Virginia and why that's not what you're paying folks in Maryland?
Sure, a couple of observations on that. One, I don't do provider contracting. I don't know all the specifics. Kaiser's in only a couple of counties in Northern Virginia and does their main hospital partner, they just have one main hospital partner. Their needs may be really different there. I'm not exactly sure what their, what that is. I do believe, I've heard from multiple people that maybe they are paying more. They did put this request in. To be totally fair, I don't think this bill has, there's no love lost between these two companies, as you can imagine. So, we'll see where it goes from there. They would like a national contract. I mean, we'll see where it lands, I guess.
Thank you.
Delegate Tavera.
Thank you. Just kind of like piggybacking on Delegate Hill's question a little bit. My understanding is that you guys are not willing to negotiate with the doctors, but I just want to be able to be clear on. Sorry, I'm tired too.
Me too.
Yeah. Yeah, that you're not willing to negotiate with the doctors, but is it that I'm sorry, I lost my train of thought. I'll be back. Give me a minute.
Yeah, no worries.
Vice Chair Cullison.
Thank you, Madam Chair. Thank you for your information. Allison, do you have other providers that are out of network?
Yeah, a ton. Yeah, as a part of a group model HMO, the strategy really is to have our 1,800 Kaiser physicians manage that. So I would say that's like the main thing any patient or provider needs to know when choosing Kaiser is, yeah, that's a trade-off for the quality of care you get, that you're getting that network.
So, and what you're saying is it's a narrow network because it's to constrain cost as much as anything. So your out-of-network providers that you have, are they accepting the rate that you are offering them?
Probably depends on specialty. I'd say I distinguish between, Kaiser does have some in-network physicians that are not Kaiser physicians, and those are, I'd say, primarily certain hospitals and also things that we need to fill network adequacy gaps. So those, I assume they're credentialing, they're contracting with Kaiser as in-network. The out-of-network, I guess this statute does apply. I think one thing we could agree with the proponents on is the way the statute works now is it ties reimbursement to the average rates from the year before. I can understand how that would create some uncertainty in the market. So we had proposed, if you tie it to 2026 rates, you can, it's not pre-No Surprises Act, but it would have the same impact on all specialties, and then, it would give some certainty in that. So, maybe that's like 5% of the way to what they want. That's I don't have a ton of negotiating room in this, but that's what I could do.
If you tied it to the 2026, would you be open to including an inflation escalator?
Yeah, totally.
Okay, thank you.
Delegate Hill, second bite at the apple.
Madam Chair, I was hungry. Allison, can you get for us, I suspect you can't give it off the top, but the radiologists, the anesthesiologists, the emergency room docs, and maybe one other group who have a high rate of offering emergency care to your patients, at in-network facilities, but they're out-of-network providers who we're trying to do, of what they would have been reimbursed in 2019 and what they are being reimbursed in 2026. If you can give us that information, I think it might be helpful.
Yeah, well, here's what I would say. Well, I'll make a couple of general points, but first I'll start and say, I highly doubt Kaiser would let me do that. You might be able to get that from DBM because they run the state employee plan.
Okay.
I would say that, Kaiser does have a narrow hospital network too, where Kaiser physicians do work in hospitals. I'm guessing we do most radiology in-house. I'd say that
But emergency. So if I show up in an ER, that's if I show up after a car accident, they're not going to take me to a Kaiser facility to get the CAT scan. They're going to do it where they are. So those radiologists who are reading that exam, right, they're not necessarily going to be in network.
Yeah, I don't know if they sent, you certainly would go to an ED wherever you're at. Whether they're sending those x-rays to be reviewed by Kaiser radiologists, that I wouldn't know.
Thank you.
Same with anesthesiology, I would say it would depend on whether they were like in network with the hospital. I mean, you know I'm saying it, or they're out of network but the hospital's in network. Yeah, so that, I'll see what I can get to.
All right, thank you.
Yeah.
Thank you, and if you could share that with the full committee. Seeing no further questions, this concludes this, Delegate Tavares.
Member, thank you. Thank you, Madam Chair. So I just wanted to make sure that I understood. What have you found to be, well, I know that we're just implementing the AHEAD care model. So how is that, have you done projections on how different the payment structure would be between the AHEAD care model and the fee-for-service?
That is still under discussion. We have been working with the HSCRC on opening up some capacity for Kaiser members at their specific hospitals that we hope would help with ED wait times and other things like that. So I think that's TBD, but we've been at the table on AHEAD and certainly we'll work with everybody on a good program there.
Well, if I could just, well, not a follow-up, just much as commentary, just making sure if there is cost savings, that it could be shifted to the payment of the doctors. Thank you.
Thank you very much. Seeing no further questions, this concludes this panel and also this hearing on House Bill 737. We have our final bill of the day, which is House Bill 808. This is the Maryland Medical Assistance Program Step Therapy Fail First Protocols, Prior Authorization, Prescription Drugs to Treat Serious Mental Illness. This is Delegate Johnson. If you want to bring your panel, and you can get started when you're ready.
Good afternoon, Madam Chair, Vice Chair, and committee members. For the record, I'm Delegate Steve Johnson. I'm here to present House Bill 808, Maryland Medical Assistance Program, Step Therapy, Fail First Protocols, and Prior Authorization, Prescription Drugs to Treat Serious Mental Illness. This bill is pretty simple. If you have a serious mental illness, you should not have to fail on medications before getting the one originally prescribed to you by your healthcare provider. When we say serious mental illness, that's exactly what we mean. This bill would apply to schizophrenia, PTSD, major depression, bipolar disorder, and a medication-induced movement disorder, which is associated with the treatment of serious mental illness. Fail First or Step Therapy is an insurance or Medicaid protocol that requires a patient to try one or more medications recommended by the insurance company prior to actually getting the medication that is recommended by their provider. That in itself should tell you something. For example, if your psychiatrist prescribes drug A, Medicaid often requires a patient to try drug B, which is usually cheaper and demonstrates that it's not always adequate treating their disorder prior to approving drug A. The patient must show how drug B has failed them first before the drug A is covered. This process can take weeks or months, and for some suffering with serious mental illness, this is detrimental and can cause them to decompensate rapidly. Now let's talk about where we've been with this bill. This bill's been introduced in the past several years, and we've tried many different iterations of it. We've tried to work with both private insurance and Department of Health. This bill, as introduced, would only apply to Medicaid patients with serious mental illness. Over the interim, we met with the department several times to shed light on the importance of this bill, to share what other states have done and impacts they've seen in cost savings and patient outcomes. We've even encouraged outreach to several Medicaid directors across the country who run programs that prohibit fail first and have seen, again, cost savings across the state and better health outcomes. We started this work right after last session, and after lots of back and forth with the department, at the end of the year, last year, MDH reached out and maintained that even though they had conversations with other states' Medicaid directors, their physical analysis still stands, and that fail first would increase the cost of the state, thus they would oppose the bill. We disagree with the department's analysis, but as a sign of good faith, this bill includes a sunset in 3 years. We will try it for 3 years. If the sky falls, we will go back to the way things are done right now. It's my belief that the sky won't fall. We've seen from other states across the country that is ending fail first results in cost savings. Michigan banned fail first for mental health medications in 2004. A recent study compared Michigan Medicaid patients with serious mental illnesses to several other states and found that the total cost of treating serious mental illness was lower in Michigan. Now, the Department of Health states their enormous physical note based on cost will be driven by shifts from generic to brand name drugs. However, Michigan's Department of Health and Human Services states that eliminating fail first protocols has not resulted in prescribers flooding Medicaid with claims for brand drugs. Utah created open access by implementing a dispense as written law for the antipsychotic drugs. That was a caveat by requirement that preferred drug list adherence remain at a certain percentage, 75% in 2019. Compliance with the preferred drug list at the end of 2019 was actually 91%. Another study published in the Journal of Managed Care illustrated how the presence of formulary restrictions on antipsychotic impacts expenditures in patients with schizophrenia. They found that states without formulary restrictions spent less than those with formulary restrictions in total medical expenditures. In fact, expenditures can be offset by savings from reduced delays in treatment, reduced provider costs such as provider visits and hospitalizations. As we all know by some of the bills we put in, physical notes don't often take into account the savings to the state we anticipate from this change. I'd also like to share some real-world scenarios in which step therapy by Medicaid has infringed on a provider's ability to care for their patients. One patient with a diagnosis of bipolar disorder was discharged on an antipsychotic medication called Latuda, but required a prior authorization to obtain that medication. They were unable to do so and were recommended a cheaper medication. This female patient failed multiple trials of mood stabilizers. She was stabilized on Vraylar, which over a month and Medicaid continued to decline the prior authorization. It took the provider multiple appeals to Maryland Medicaid to get approved, derailing the provider's ability to care for their patient. When individuals with serious mental illness can't get timely access to the care they need, they decompensate. Untreated schizophrenia causes decline in cognitive function. Untreated bipolar can lead to episodes becoming more frequent, severe, and prolonged. Untreated PTSD can lead to increased suicidal ideation. Many of these serious mental illnesses lead to increased rates of homelessness and justice involvement when left untreated. So there's about 37 states that have enacted legislation to regulate, limit, or reform the use of step therapy. With this, I respectfully ask for a favorable report on House Bill 808. Thank you. Whoever wants to go next.
Thank you for the opportunity to speak today. I'm Michelle Lifshin, representing Honor Own of Maryland, in support of House Bill 808. In addition to our written testimony, I want to share my personal experience. It took me 6 years of cycling through multiple psychiatric medications to ultimately find one that was effective for me and that did not cause such severe side effects. For years, my ability to function was impaired on a daily basis. In my early 20s, I was prescribed a series of generic medications that are typically approved by insurance. The first one was yet again not effective and gave me side effects so unfamiliar, sudden, and severe that I had to take a leave of absence from school and enter into intensive treatment. I tried other medications that did not help me manage my symptoms and also struggled with the side effects. My psychiatrist finally suggested that I try a newer medication, not typically approved by insurance. The prior authorization delayed my treatment for over a month. It took weeks for it to be reviewed and denied by my insurance, and then again for my psychiatrist to contest and resubmit, only for it to be denied a second time. It was finally my pharmacist who advocated with my insurance company on my behalf. And if I had not got that approval for that newer medication approved, I would have not been able to finish my education, work full-time, and enjoy a full life. Delaying treatment can have devastating consequences that lead to suffering and need for costly interventions. This bill would improve care by protecting patient-doctor decision-making and promoting timely access to treatment that could help someone live their full life. We urge a favorable report. Thank you.
Thank you, Madam Chair, Madam Vice Chair, members of the committee. My name is Michael Gray. I'm representing NAMI Maryland. NAMI is the National Alliance on Mental Illness, and NAMI Maryland is a state organization of NAMI. I want to thank Delegate Johnson for bringing this very important bill. And Delegate Johnson articulated all the good reasons to report this bill favorably and for the General Assembly to pass it into law. So I want to ask you to focus on a couple things. One of them is in the fiscal note. As Delegate Johnson said, the fiscal note has a big number on it, but it's got an even more important piece of information. The last page, page 3 of the fiscal note, in the second to last paragraph, the last sentence of that paragraph says, expenditures may be offset by savings from reduced delays in treatment and reduced medical costs such as provider visits and hospitalizations. That's exactly what we think you'll see if this bill passes into law. We know that in Georgia, they instituted step therapy, fail first protocols on mental health medications, and they saw slight increase in drug costs, but such an increase in overall cost of treating patients that it offset that, and they had a net increase in state cost. That's what we're trying to avoid here, just the opposite. We want to do what they did in Michigan, where they passed a law just like this over 20 years ago, and they have seen overall savings from Medicaid expenditures and the cost to treat patients. That's one thing. The other is a question, maybe an observation for the committee, and that's this whole issue of fail first protocols in general. You know, when a medical doctor makes a mistake in the course of their job that's so egregious it causes harm to the patient, that person and the hospital where they work is liable for that. But what happens when someone is denied the medication they need, their mental illness symptoms decompensate, and then harm comes to that person or others? If they experience suicidal ideation and tragedy happens because they couldn't get the medication they need, who's responsible? The answer is Medicaid didn't pay for that drug, but there's nothing in place to cover that liability, to make that right. So we're asking you to pass this bill. Thank you.
Good evening now, members of the committee. Dan Rabbit, Policy Director at Behavioral Health System Baltimore, in strong support of HB 808. In our role of overseeing the behavioral health system in Baltimore City, we support programs that are designed to keep people experiencing serious mental illness safe in the community. These are programs like residential rehabilitation programs, assertive community treatment programs, maybe assisted outpatient treatment programs at some point in the near future. And finding effective medication to support folks who are in those programs are absolutely essential for any of these programs working well. They're also very expensive programs. They're the highest end programs in our system. And so making sure that people diagnosed with bipolar, with schizophrenia, with serious depression, major depression, have effective medications is very important for cost, but also very important for the stability of these individuals. Psychotropic medications are just different than other types of medications. People routinely respond very differently from one drug in the same class as to the other. It can take years to identify an effective medication regimen, and a gap in that effective regimen can have lifelong impacts. I used to work at a residential rehabilitation program where I saw individuals who are stable on a medication, they had to stop that medication for whatever reason, and they would decompensate. They would take the medication again, like maybe the gap was only 4 weeks, 6 weeks, 8 weeks, and in some cases, they never got their symptoms back under control. Avoiding those sorts of gaps is really critical. The decisions made should be, decisions about medication should be made by the consumer and their doctor, not by favorable formularies negotiated with pharmaceutical companies. This bill has a sunset. There's been a lot of negotiations. We believe that a good compromise has been met, and we urge the committee to support HB 808. Thank you.
Once again, members of the committee, for the record, my name is Dana Kaufman. I'm here on behalf of MedChi. I agree with everything that has been said as far as the importance of making sure that medication can be given timely. What I'm going to say is a little different. I've been working on health insurance issues now for MedChi for 12 years. And in that time, I have never had a health insurance issue where the opponents didn't raise major fiscal concerns and the sky was going to fall and the premiums were going to skyrocket. And that has not been the case on most of those bills or any of those bills. 2 years ago on the prior authorization bill, we had a major fiscal note given to us. That bill has now been in effect for over a year. And we're not seeing skyrocketing premiums. And I think one of the issues that we always do need to remember is what was said before. There is a societal cost for the offset by making sure individuals get their drugs at a timely manner. We've taken great strides in Medicaid to ensure that individuals and patients have the ability to get their drugs in a timely manner. We have removed those barriers. What we're asking is those same barriers be removed in Medicaid. And again, with the 3-year sunset, that will give us the opportunity to see if the concern is actually justified. So we asked you for a favorable vote. Thank you.
And I guess I'm last, and I'll be quick. Madam Chair, Madam Vice Chair, members of the committee, Dan Martin with the Mental Health Association of Maryland. This committee knows better than any others about the workforce challenges that we're facing in the behavioral health space and the care challenges that we're facing. And despite those challenges, we allow payer practices that undermine the clinicians that we do have and allow payers to just overrule treatment decisions and substitute their own preferences. And it's really hard for people to get the care that they need when they need it. There are, like we said, workforce shortages, network adequacy challenges, stigma to contend with. And then on top of that, we allow these barriers to care that lead to a worsening of illness and an escalation of symptoms. And then we wonder why people with mental health issues are disproportionately ending up in hospital emergency departments. So these are unfair, dangerous practices, and we urge you to put a stop to them by passing House Bill 808. Thank you.
Thank you for your testimony. Do I have questions from the members for this panel? Seeing none, I have a question. I know that you put a 3-year sunset on it. I also saw that in 2024, we actually had trigger language if it was, beyond the budget. And looking at the Michigan financial modeling, it looks like we would see a significant, not just advancing better healthcare, but a significant savings. Had you considered the trigger language for this bill, or was it like an either or with the sunset?
I did look at that, and I would be happy to consider whatever the committee thinks is appropriate, but this is pretty narrowly focused on Medicaid and just for certain mental illnesses. So this is more of a pilot for us to try for 3 years. Like I said, it's narrowly scoped, so we can have more of a handle on it and watch it over those 3 years. But if the committee feels that that amendment would be appropriate, I'm open to it.
Thank you very much. Did you have I know we have one more testimony. We have a favorable with amendment. I just want to mention there are no unfavorables testifying today. This is a priority of this committee. This has been a long time priority of this committee. We've heard these fail first protocols, and that they are a cost containment tool in the toolbox, but the data doesn't seem to demonstrate that that is actually accurate. So I want us to consider carefully what we can do, because we know we have a health crisis, we know that we have a workforce shortage, and we know that the adverse outcomes of medication that is not actually meeting the need of these diagnoses can be extremely significant. So seeing no more questions, I will just say that let's continue to work and get this done. Thank you. This concludes the bill hearing on House Bill 808 and concludes our hearings for today.
Thanks, guys.
I'm so sorry. That doesn't conclude it. We have a favorable with amendment. Do we have Evelyn Burton? Is she here? She's virtual. Oh, that's why I didn't see her. My apologies, Evelyn. I was looking for you and I didn't see you, and I just realized you're virtual. So continuing the House Bill 808, Evelyn Burton, you can start your testimony.
Thank you very much. Hello, I'm Evelyn Burton, the Volunteer Maryland Advocacy Chair for Schizophrenia and Psychosis Action Alliance. As families of those with psychotic brain disorders, we too often see the tragic outcomes of untreated and inappropriately treated mental illness. Dr. Thomas Insel, a past director of NIMH, said, quote, "For an active psychotic illness, there is a 15-fold reduction in risk of homicide with treatment. Non-adherence to antipsychotic treatment results in a 4-fold risk of suicide, increased hospitalization, use of emergency psychiatric services, arrests, and greater substance use. Unlike most other illnesses, for psychotic illnesses, there may be only one chance to prescribe the most effective and tolerable medication before extreme adverse consequences. Only the individual's physician can judge which medication that is. Insurance restrictions risk medication refusal due to adverse side effects. The Schaefer Center for Health Policy and Economics found Medicaid formulary restrictions for serious mental illness save lives, saves little, if any, money on the drug, but does increase overall Medicaid spending, especially for inpatient hospital care and rise in jail costs. Unfortunately, this overall savings is not itemized on the fiscal note. We have two suggested amendments. In the list of diagnoses, change the word schizophrenia to schizophrenia spectrum and other psychotic disorders, and change bipolar to bipolar and related disorders. This would ensure that codes used by Medicaid for billing all serious psychotic illnesses, such as schizoaffective disorder with potentially tragic outcomes, will also be exempt from step therapy and prior authorization requirements. HB 808 can save money, reduce tragedies of suicide, death, violence, homelessness, and incarceration. Excuse me. So please support it. Thank you.
Thank you very much for your testimony. Are there any questions from the members for this witness? Seeing none, thank you for your testimony. This does actually conclude the hearing on House Bill 808 and concludes our hearings for today.